model with much more improved in the circumstances and the opinion of the different fraternity of general physicians, general neurologists, as well as general practitioners. So our aim is our message should go to the masses and to help the patient, them, and also to the patient. And now may I request Dr. Gagandeep and Dr. Girish Mathur and Dr. Jyotirmay Pal to say few words. Dr. Gagandeep.
Thank you, Dr. Maheshwari. I'm so pleased to be here today, and it's actually the fruits of hard work of so many people, my predecessor, Dr. Nirmal Surya, and the hard work of Dr. Maheshwari. And the topic, Dr. Maheshwari was very clear, it should be stroke. And when he said stroke, I was reminded of some 30 years ago. I was a house doctor in the internal medicine department. And it was a very busy night. I was on call and it was a really busy night. And we had huge number of admissions. And many of the cases admitted that they were stroke patients. So in the morning, I had a very clinically astute professor of internal medicine. There were no neurologists at that time. So, he came for rounds and I started presenting the cases. When I presented the first case, I said, sir, this patient has a right hemiplegia. And he examined the patient and he said, no, this is a left hemiplegia. So the next patient, I said, sir, this patient has a left hemiplegia. So he again examined the patient and he said, Gagandeep, no, this patient has a right hemiplegia. So this thing went off. So he said, okay, Gagandeep, do one thing. Put all the right hemiplegias on the right side and all the left hemiplegias on the left side of the ward. And that was perhaps 1990s. That's how stroke. There used to be a relatively nihilistic outlook towards stroke. But then I think even today and in our hospital and so many hospitals across the country, stroke is managed not just by neurologists, but by internists, largely due to the paucity of neurologists. But there are so many cross-disciplinary, and as Dr. Maheshwari has crafted this program, clearly it's just not neurology. There are so many other things that go into the successful management of a stroke patient. So that's why we are here. It's such a great pleasure that our dear colleagues from the Association of Physicians of India, from which probably the NSI and the Indian Academy of Neurology ultimately evolved. So our API president, Professor Girish Mathur is here. Welcome, sir. Dr. Jyotirmay Pal, the Dean of the Indian College of Physicians, Dr. Muruganathan. I remember you, sir, very well when you had come to Ludhiana, where Dr. Wander and Dr. Bansal had and other colleagues had organized that beautiful conference, API conference. I clearly remember that time. And of course, we have an excellent galaxy of speakers. Dr. Padma, who is the Director of Neurosciences at the All India Institute of Medical Sciences, and an excellent panel of speakers whom I would request Dr. Maheshwari would probably introduce them, but it is over to you, Dr. Girish Mathur, to say a few words.
Thank you, Dr. Gagandeep. It's my privilege and pleasure to extend a warm welcome on behalf of API at this second series of joint stroke symposium organized by IAN and API. My regards to President API, Dr. Gagandeep Singh, Secretary Dr. Meenakshi Sundaram, Dean ICP Dr. Jyotirmay Pal, Dr. Nirmal Surya, Dr. Muruganathan, Dr. Maheshwari, Dr. Rajendra Bansal, and all the panelists, Dr. Padma Srivastava. Stroke, as we all know, is the second most common cause of death worldwide and the third most common cause of disability. And the advancement in the neurovascular imaging has revolutionized the treatment during last 3 decades, I think. And the dominant theme today is the neurovascular imaging and the speed and diagnosis of treatment. It is truly heartening to note that the topics selected for today's symposium are physician-centric, are of much use to the common practicing physicians. We have legendary speakers for today's symposium, Dr. Mugunathan, Dr. Padma Srivastav, Dr. Shashank Joshi, Dr. G.S. Wander, and panelists, Dr. Subhash Kaul, Dr. Kameshwar Prasad, Dr. Selja, Dr. Gorthi. I hope we are going to have a very enlightened discussion this evening. My very best wishes for the success of the program. Thank you so much, Dr. Gagan, Dr. P.K. Maheshwari, for giving me the opportunity to join this session. Thank you so much.
Dr. Jyotirmay Pal, sir, say a few words.
Yes. Namaskar. As Dean Indian College of Physicians, I am very optimistic regarding the prospect and success of the joint symposium by Association of Physicians of India and Indian Association of Neurology. From last 1 year, I am observing such effort led by Dr. P.K. Maheshwari, who is taking a tremendous effort to structure such a symposium and has picked up very common, he's a common man between the API and neurology. So probably that is the reason why he has picked up the very common clinical medical emergency that is often met by the physician practicing across, not only in India, across the globe. And stroke is one of them. It is a very serious medical emergency. We have a 2 targets. First, we have to save the life, to decrease the mortality, and we have to give the rehabilitation. We have to decrease the disability. And stroke is very common. Dr. Mathur has already told. I got some data from Neurology India published in 2021. From 1970 to 2000, there was a 100% increase of the stroke case. And from 2000 to 2019, another 100% increase of the stroke case. So stroke case is exponentially increasing in Indian subcontinent, maybe due to the high burden of different non-communicable disease like diabetic hypertension and maybe some genetical predisposition. So every physician, stroke management is a bread and butter. So I wish success of this program, but I have an appeal to Dr. Gagan Singh, Dr. P.K. Maheshwari, that apart from this CME, we should come out with some status paper on stroke management, jointly published by Neurology, IIN and API, and that can be very helpful for the practicing from the tertiary care to the primary health center. In West Bengal, recently we have started these things. There are 3 tier of management policy. One at the rural, one is the district level, one at the medical college level. So whether in the same way we can publish some status paper on management of stroke, management of acute infection, CNA, management of severe disorder, management of head injury like this. So hope we'll come out with much better prospect. Thank you. Thank you, Dr. Maheshwari. Over to you.
Thank you, sir, for your suggestion. And I'll request Dr. Gagandeep, Dr. Girish Mathur, and yourself to make up such guidelines so that it will be for an help to every person. So may I request Dr. Padma?
Just one suggestion, Dr. Maheshwari. There is already a guideline. If people should go to Ministry of Health and Family Welfare website, there is a national guideline for prevention and management of stroke. And I was privileged to chair that committee which has produced this. It is already on the website of Ministry of Health, and it's very comprehensive. All my colleagues, including Dr. Padma, Dr. Kaul, Dr. Rohit Bhatia, and Dr. Of course, Sunil Narayan, Dr. Selja, I mean, so many people have contributed in that. And it is a very comprehensive guideline, including rehabilitation. And I would request people to refer to it. It has been done with great effort, and I think it's very useful.
Thank you, sir, for sharing the things. May I request Dr. Padma, who is professor and head of the Department of Neurology, and her area of interest is in the thrombolysis. She has been awarded Padam Shri by President of India, and her main work is in the thrombosis. And there's so many publications and so many citations. I think that already 1 hour will go. May I request Dr. Padma to deliver her talk on management of stroke patient in emergency room.
Thank you, sir.
Dr. Padma.
Yes, thank you so much for the kind introduction and thank you for giving me this opportunity. And good evening to my teacher, Professor Prasad, and all the senior physicians and my dear colleagues, and most of them are extremely close to me. So it's an honor, and let me, can I have the first slide, please?
Yes.
There we are. Can you see my slides?
No.
No. Now audible. No. Slide not.
You cannot see the slides. I'm sharing them again.
Yeah.
Can you see it now?
Yes, ma'am. Put it on slide.
Okay, so yeah,
Yeah.
this is on the slideshow. Okay,
Yeah,
thank
yeah.
you. So yes, so we have already set the the ball rolling about how important managing acute ischemic stroke in the current scenario where the stroke statistics are truly humongous. As we speak now, the current ICMR figures say that every 20 seconds there is a stroke and every 2 minutes there's a stroke death, and that's truly humongous. And that said, we also know that the management of an acute ischemic event is extremely time sensitive. So it is the first contact person who would actually be most responsible, and that's going to be the physicians. And how to empower the physicians to manage an acute stroke is the mandate of all the across, in fact, the world, and especially the developing world. So some of the basic tenets is that when we say it's time sensitive is because as long as an artery is blocked, it stays blocked. There are zillions and trillions of neurons which are lost forever. And we are not just, mandating in terms of a stroke outcome being a death or a disability. We're also looking at a brain which is aged tremendously, and that's cognition. And aging is not even taken, ceremoniously as an outcome measure. When you look at it, we count the deaths and disabilities. So the other important tenet is that although time is crucial, it's the basic vertical on which we build all our management strategies. We also know that there is a tissue-based assessment, because in 1 hour we have an opportunity of salvaging 9% of the critically perfused jeopardized cerebral tissue. Loosely we coin it as penumbra, and this is not going to vanish as the time elapses. So we do still have into the ambit of an opportunity of managing these patients, that percentage of patients wherein beyond the rigid time window frames, they would still have this viable brain tissue, which can be salvaged. So the current strategies as they exist is that, yes, we have intravenous tissue plasminogen activator to be given within 4.5 hours, and we have two important thrombolytics which are available with us, which are now in use very prominently and very commonly, both alteplase and tenecteplase. And the endovascular treatment or the mechanical removal of the clot, there the time window frames are very encouragingly increasing. So we had 6 hours, it went to 8 and 12 and 24 hours, and probably the dots say that we are still looking at zones of improving this time window. Aspirin in the first 48 hours, this has been established after 48,000 patients data. And managing in a stroke care unit, and that's the most unglamorous part, but that's the care actually which improves a stroke outcome by 40%. And the decompression hemicraniectomy, which definitely salvages the death part of it, and then still searching for the holy grail, which is the neuroprotection. So the 4 important things which had actually made this tectonic shift from something which is very nihilistic, as Dr. Gagandev was saying, to one of hope, one of aggression, one of this active intervention. That irrespective of what time the patient has actually reached the emergency, you can do something to improve the outcome. In that, the 4 basic things which have caused this kind of paradigm shift is managing a patient in a stroke care unit, use of aspirin, first 48 hours, hemicraniectomy, but it is this thrombolytic program, that is intravenous and avascular thrombectomy, which actually has proven a game changer, because this is where you take this as you know, the what I would say as the fruit in the ball to say to the policymakers and implementers, like, look, you can make a difference. You put the stroke chain of survival in place. But let's start at, you know, the initial assessment when a patient comes to you to the emergency. Now, what are those conditions where who would need an admission? Whenever there is a depressed level of consciousness, ICH, they need an admission. Large strokes with edema, cerebellar, you know, the ones which are there in the posterior fossa. Whenever there's a cardiovascular instability, when you're contemplating, or this is a candidate for intravenous or a vascular thrombectomy, obviously that's a no-brainer. Whenever you suspect a large artery, especially in the posterior circulation, when there is severe dysarthria or dysphagia. Now, these are the guidelines where you say that when a patient is coming to a district hospital level, when a physician is looking at it, and then they would require an admission. I would say that all strokes need admission. Now, the lab tests, there may be a whole lot of them, but remember that the mandatory test would be your point of sugar and the blood pressure, really. And if you have a point of care system, you can do the PT-INR as well. But toxicology screen, sedimentation rate, homocysteine, these are not the ones which you try and do in an emergency, you know, level. And certainly not a chest X-ray. Now, look at a lot of them. They should cut into your time interval of intervention. So the mandatory here, certainly platelet count and CBC and differential, if you could do that. But a point of care PT-INR, if there is this, that I'm going to intervene by giving a thrombolysis, that would help, although it's not mandatory in common garden variety of patients, so not on anticoagulation. But blood sugar, blood pressure, that's most important. Now, the guidelines are there, and as Professor Prasad said, we have our own guidelines, and the latest of them have just been released about 6 weeks ago. The latest part of the guidelines, which are there on the website, you can all have a look at that. But what is a general supportive care in the emergency treatment of an acute stroke? Now, airway support and ventilatory assistance are recommended when you feel that it is required. When there is a bulbar dysfunction, when there is a compromise of airway, you feel that the saturation may not be okay, you put in your finger probe and the saturation is low. So you have to maintain your oxygen saturation much above 94%. Supplemental oxygen, just don't go about, just put them onto an oxygen, you know, cylinder, or no, you don't. And certainly no place for hyperbaric oxygen therapy at all. Now, blood pressure is the really, I think, the cornerstone of a lot of outcomes happen, even if you intervene or you don't intervene, and when you're intervening. So the maintenance of a systemic perfusion levels are absolutely important. So there is a reason to intervene, and there is a reason when you should not be intervening. When you are giving thrombolysis, or when you're intervening in terms of a clot lysing or clot removal strategy, there the blood pressure has to be less than 185/110. In the other situations, you need to have a pressure head. The mean arterial pressure has to be definitely not less than 130. So you need to have a systolic pretty much higher. Okay, so and in that situation, how do you manage? Labetalol is our go-to drug. We have it on our, you know, our pharmacopoeia in the emergency. You give 10 milligrams stat, you can repeat it, you know, and they say you can go up to 300 milligrams. We've never done that. We definitely did repeat, you know, a couple of times. You can give an infusion as well. Labetalol is a drug which we do. It is short acting. It's not really reducing your pressure too much, and gives you that opportunity to intervene fast if you have to thrombolyze a patient. Nicardipine and all others are there out there in print, in the guidelines. Certainly, they're not available across different practice settings, so I'm not bothered about that. Now, then the blood sugar. You know, this interesting thing, and I'm sure Professor Shashank Joshi will also touch about that, is that now they say that too tight a control is not really recommended. So you have to have a glycemia somewhere between 140 to 180 milligrams percentage. You don't have hypoglycemia. That's mandatory. There was once, a contraindication to thrombolysis if you had very high sugars. That has been taken out now. But yes, you can definitely reduce it. Keep it between 140 and 180 milligrams %. Then the question of giving antiplatelets. All right, you have a candidate who is for thrombolysis. You can do it thrombolysis. Then don't give aspirin. But in those situations where you cannot, they've come beyond the time window frames, and there are other contraindications. And if there are, now we have guidelines of picking up a minor or moderate stroke, therein you can give double antiplatelets for a short duration of time. And I'll come to that a little later, because there has been a change of thinking about usage of double antiplatelets. This is a stroke prone state, so you don't want a recurrence happening immediately. So you give this, but for a short duration of time. You don't continue to give double antiplatelets for a long duration. Aspirin you can give, obviously. There's no real reason to immediately start anticoagulation for any reason. Okay, but you have to look at it. For that, you need to subtype the stroke, and there are subtypes of stroke where you would need anticoagulation. So the general supportive care will remain the same, the ABC, wherein you need to have an airway, you need to look at the oxygen saturation, you need to make sure that saturation is above 95%. Otherwise, you're not forcibly intubating or putting the patient on oxygen. And hypothermia is really important. For every 1 degree rise of temperature, the stroke outcome deteriorates. All right, so it's very essential that you have to preempt and prevent infections and fever. There are stroke situations where there may be fever happening because of a stroke. Reduce the fever just using paracetamol. Patient positioning and monitoring is so crucial. I kind of overemphasize this fact in simple things. So positioning a patient, prevention of aspiration. When do you start swallowing? When do you start feeding? What are called as FEST protocols. There's such integral part of a stroke unit care, and I'll tell you about that a little later. So a blood pressure is something that I want to stress a little bit more, because that comes under the emergency management done by the physician. There are a lot of reasons why BP increases after an acute event. Acute stress. There could be pre-existing hypertension. The guy did not have an antihypertensive that day. The strokes will be an acute situation where the BP goes up. It's a reaction, because you need, when the blood pressure is, when the blood vessel is blocked, then there is a host, a defense mechanism. You need to increase it so that you can overcome that. That's the reason why sometimes the strokes might happen, the stress, the stroke severity, and so on and so forth. But then, how do you manage that? There are a lot of studies wherein they said that, look, if you reduce your blood pressure fast enough, very soon enough, and using all these, methods, you could do better, but none of them really improve. So we're not doing it. We're sticking to this protocol of maintaining the systolic 220, diastolic 120, but less than 220, less than 120, keeping the pressure at least 130. But when you really have to do intervention like thrombolysis, get it down to less than 185 by 110. And after thrombolysis, you'll have to keep it down to less than 180 by 105. So there are situations wherein you immediately intervene and you drop the blood pressure when there is an endocrine damage. And this is again a no-brainer. This is this guideline has been there for years now in terms of concomitant acute MI, acute renal failure, aortic dissection, pulmonary edema, and so on. And they're there in almost all guidelines. The change in thinking in terms of giving DUATs or double antiplatelets immediately after a stroke has come out with, a lot of studies, which included, studies such as, the Chinese trials and other trials. I'm not going to get into that. But remember, in a stroke-prone state, you do give this double antiplatelets for the first 21 days. Now, regarding the blood pressure, when I talk of change in thinking, this is an acute hemorrhagic stroke. Therein, there have been studies which actually have tried to point out what is the sweet spot wherein you can drop in your blood pressure quickly and then maintain it. Now, it seems that after an acute hemorrhagic stroke, you can drop the blood pressure in the first 4 hours if you intervene. Drop it within the first 1 hour to 140, but don't go less than that. You maintain that in the first 24 hours that way. The fluids, electrolytes, and all that, is any critical care management. And the role of antiplatelets in acute ischemic event, oral aspirin in the first 48 hours, level 1 evidence. the usefulness of clopidogrel as such has not been established, but remember when I talk about DUAT in the prevention of stroke in the stroke-prone state in the first 21 days, that is 75 milligrams of clopidogrel and 150 or 75 aspirin. Now, there is really no role for the other drugs like tirofiban or iptafibatide, but they're there in certain clinical trials. As such, most of them come in certain interventions when people undertake. Anticoagulation, urgent anticoagulation preventing early recurrence is not recommended. Class 3 recommendations. There are certain stroke subtypes, and you do get into these kind of situations between a devil and a deep sea when there is a free floating thrombus and is an active cardioembolic source therein. It is open to study. And when to start anticoagulation, when it is indicated after an acute event, you do take the 2-6-12-day principle, which has been borrowed from the European Heart Rhythm Society, where if it is a very minor stroke in the first 48 hours, moderate, even take about a week, but large strokes, wait for at least 14 days. The administration of high-dose albumin, not established. Drug-induced hypertension, only in clinical trials. Do you augment cerebral blood flow? Only in clinical trials. Hemodilution, not recommended. Pentoxifylline, not recommended. And look at this slide, ladies and gentlemen, because, once there is an acute ischemic event, you have so many events which are happening in parallel, in vertical, and they're also connected to each other. That means once there is a clot, it sets forth this cascade of ischemic events, which is detrimental. So the glutamate release is important, but a few seconds later, it becomes detrimental. So unless for a panacea for all evils, either you need a bunch of drugs or one single magic bullet. We haven't gone there yet. Therefore, there is no single neuroprotectant which has been approved. We're still searching for the holy grail. Okay. So the role of neuroprotection, no neuroprotectant, unfortunately, including citicoline, edaravone in this class 3. Statin therapy you can continue during acute period, which is reasonable. Induced hypothermia, only in clinical trials. And as I said before, hyperbaric, normobaric. Clinical trials, in fact, all the clinical trials so far have really not said that. So search for holy grail for neuroprotection continues. Now come to treatment of edema and raise intracranial pressure. Reduce ICP, all right? So maintain adequate cerebral perfusion and avoid worsening of brain ischemia as to prevent secondary brain injury from herniation. So there is a great role for hemicraniectomy and acute ischemic stroke in a malignant hemi, when there is an MCA infarct. Now, when you have a malignant MCA infarct, this whole cutoff, this MCA is cut off, this whole hemisphere is damaged. Now, this is caused, this works like a big ball. It pushes the normal brain and can cause herniation, and the normal brain is getting affected. So what do? You actually take out a big flap of the cranium and what is called as a white hemicraniectomy, and allow the brain to expand outside and not push the normal brain. And this, the number needed to treat, which is a useful comparing, contrasting different therapeutic regimens, it is 2. So if you do 2 cases of decompression hemicraniectomy in a malignant MCA, you're preventing 1 death. That's humongous. Okay. Now, what happens to the disability? Now, that is, there are certain controversies in that, but then a lot of evidence now is in favor that younger patients definitely, but even older patients, there are certain caveats. Dominant, non-dominant, aphasia, no aphasia, all those things now are loosely connotated. You do go ahead and do this. Similarly, when there is a posterior fossa lesions, when there are cerebellar big infarcts, especially when they're compressing the posterior, the fourth ventricle, you should definitely, it's an indication for surgery, you must refer for surgery. So in MCI or the malignant cerebral infarctions, the mortality is really high, about 80%. And the decompression hemicraniectomy is a life-saving procedure. And as I told you, quality of life, and let's not get into that. There's still gray zones there. Okay, so major infarctions require measures to decrease brain edema. Class 1, decompressive surgical evacuation, class 1. And for malignant edema, cerebral hemisphere, potentially life-saving, class 1. Post-stroke epilepsy is treated as any other epilepsy, class 1. Now, the placement of a ventricular drain is useful in patients with acute hydrocephalus, that's class 1 again. Steroids, no there. Prophylactic use of epileptic drugs, not recommended, class 3 recommendation. Now that is an slide on stroke unit care, which I said it is probably the non-glamorous part. People think that I know this. They don't do it. Essentially, stroke unit care is a dedicated personnel looking after the stroke victims in a dedicated geographical area. So this involves positioning the FES protocols, maintaining the blood pressure, taking care of fluid electrolytes, prevention of deep venous thrombosis, prevention of aspiration, prevention of infection, and early rehabilitation. Although these are all modalities which you may individually see that it is a very routine thing, it's essentially not done. And you would be amazed if just doing this can better a stroke outcome, even if you're not immediately intervening and you don't have those strategies of doing a high-end intervention. So the stroke unit monitoring is what I said again for want of care, and the time part of it, I'm going to skip all this. I will quickly come to the the protocol for swallowing test. This is one of those things that Professor Prasad is so very passionate about, this FES protocols, because if this could be undertaken at a district level by physicians, this can really go a long way. Simple things. These tests are available. You can take a GUS protocol. You can use any protocol that is useful for you. Essentially, what it mandates is positioning, knowing when to start the feeding. You should know, you should know the kind of speech, the bulbar features, which would indicate that this patient is not really, obviously, when the sensorium is not good, you're not going to stuff things into the mouth. And how do you start? Is there a strong cough? Is there a strong clear voice? No need for suction. And then you start off giving little, amounts of water. Then you graduate to semi-solid and solid. So these are all well laid out procedures which are there, and you do it. Now, very quickly, few slides about systemic complications after acute stroke, which is dealt by physicians. The cardiac complications can happen. You can have concomitant MI, you can have congestive heart failure, and the risk factors is when you have a pre-existing cardiac issue, diabetes, severe strokes, renal insufficiency. They said that when the creatinine levels are more than 2, it's a big risk factor, and prolonged QTC interval on an ECG. MI can happen. This can happen. You can actually have concomitant, and when you actually do an ECG, you may have these ECG changes with heart of stroke and not really indicative of something happening in the heart. However, you can definitely have an concomitant acute MI, and there are risk factors in those patients wherein this can happen, and you should be, these are the red flags, and you should be aware of that. The neural substrate for cardiac arrhythmias is known, and especially when, this is for CHF, there is this Takotsubo syndrome. This is stress cardiomyopathy, and it is seen when there is, especially in the right insular, involvement in terms of ischemia. It has been described even in bleeds. It's been described even in subarachnoid hemorrhage, wherein it's stunned myocardium. There's this acute stressful situation. This is neurogenic, and you will find this troponin changes. You will have troponin levels which go up. ECG changes there. It can reverse. So this is generally seen in women, and strokes involving the insular region and extensive brainstem involvement. Pulmonary complications is so common. One of the commonest causes of death after acute stroke is aspiration pneumonia. So older individuals, speech impairment, especially when the bulb is involved, when there is a brainstem involvement, when there is a bulbar infection, they have a pause speech, they have this gurgling sound, they can't swallow. And also in patients who have a cognitive impairment, there is decreased consciousness, which is again a no-brainer. In such situations, multiple infarcts, pre-existing disability score, all of them can predispose to aspiration and pneumonia. So how do you prevent them? Again, positioning, nursing, oral suctioning, dental hygiene. It's amazing how much oral dental hygiene goes such a long way. Preventing aspiration, preventing infection, those oral bacteria, big things, they aspirate, and that leads to pneumonia. So there's simple things that can be done by good nursing care in a stroke unit. So what are the reasons for hypoxemia after stroke? Could be central regulation of respiration. There are a lot of sleep, apneas, and there's a disordered breathing because of an acute event or a pre-existing sleep apnea conditions. weakness of respiratory muscles, presence of aspiration pneumonia, atelectasis, and pulmonary embolism. So the predisposing factors again would be large strokes, again, elderly individuals, swallowing impairment, and pre-existing cardiac and pulmonary conditions. So you should be aware of the fact that there could be stroke disordered breathing. And look at all this, and you should be aware of it, especially when there is an individual with an increased neck circumference. Red flag for the presence of obstructive sleep apnea. They may not be aware of it. They may have that as a pre-existing condition. And there you should be aware of it and try and take care of that. A whole host of gastrointestinal complications may be there. And this is the interface, between neurology and gastroenterology. There could be dysphagia, there could be hemorrhage, there could be fecal incontinence. And there are a lot of factors which they independently predict the occurrence of GI bleeds. So the patients therefore are prophylactic, either proton pump inhibitors or antacids, and it's important. There could be pre-existing conditions or other situations which can predispose to that. And incontinence, don't you know, it's such an important and often seen condition, and so disabling. And in advanced age, large disabling strokes with sensorial problems, and also certain medications which predispose to that. Avoid these kind of drugs. Okay. And so what do? You avoid unnecessary catheterization, meticulous catheter care, meticulous central line cares. Sometimes you can use coated catheters. Okay. So the last one would be prevention of DVT and pulmonary embolism. I can't overemphasize this. So even in acute hemorrhagic stroke, you can use once a day low molecular heparin as a prophylactic. And people have actually given deep venous thrombosis, the DVT pumps. You can use other methods, frequent changing of positions. It is, it seems as though I know about it. But the thing is that there should be someone who's there regulating and making it a mandatory intervention by the nursing personnel. That's the importance of a stroke unit care. The others, of course, central post-stroke pain, fever, musculoskeletal complications, fractures, fatigue, depression, and stress ulcer, the decubitus ulcers. So care of a patient with stroke is often complicated by occurrence of these lot of adverse medical events. And the stroke unit success is because of this, you preempt, you prevent, and you early treatment of these situations. And that's the personnel who know about it, and they are dedicated to this condition that it may not happen. So understanding of these is not optimal, unfortunately, at this point of time. So this is where, the awareness and empowering the physicians to manage this becomes extremely important. The stroke management is multi-speciality. It is multi-pronged for bettering the outcome. Okay, and this is where the recommendations also come for a comprehensive specialized stroke care units, incorporating rehabilitation class 1 recommendation, and you have all these things. Okay, so I think I'm overstepping the time. I'm sorry about it. I think the rehab part, I'm sure, is going to be covered, so I will skip this too as well. And you must always have, I think I would always say that wherever the stroke setting is, please have your own audit of stroke performance measures. Whenever you discharge a patient of stroke, please see that these audit measures are there. Simple things. You say stop smoking. And I see about 12 to 15 drugs which come out and they miss out aspirin. They'll have citicoline, they'll have everything else, they'll have 100 other drugs, and aspirin is missed out. So please understand that, and even a discharge plan becomes extremely important. Before you discharge, you need to subtype, especially in ischemic event, as to what is the subtype of the stroke. And the prevention program would come depending upon what stroke subtype it is. So all these are standard stroke performance measures, and never ever give up on your stroke patient. Thank you.
Thank you, Dr. Padma, with your overview and emotional appeal for smoking, etc., etc. Now, may I request Dr. Muruganathan sir to speak on management of hypertension in the stroke. Dr. Muruganathan sir, is a professor, former emeritus professor, the Tamil Nadu MGR University, international advisor for Royal College of Physicians, Glasgow, international member of the Medical Education Board of RCP, Glasgow, chairman IMA Hypertension, past president of API, past president of Hypertension Society of India, and many more things. May I request Dr. Muruganathan sir, please.
Thank you. Thank you, Mageshwari. And my dear brother, Dr. Grees Mathur, Jyotirmay Paul, Dr. Singh, Surya, and my lovable sister Padma, the future speaker, my brother Shashank, and all my good friends and brothers and sisters. Stroke is among the 3 leading causes of death. Other 2 are heart attacks or cancer. Stroke can be classified into 2 types, ischemic and hemorrhagic. Majority of the strokes, 60 to 70%, are ischemic and the rest are hemorrhagic type. Hypertension is the leading modifiable risk factor for both types of stroke. Appropriate control of blood pressure is required to ensure good outcome in patients with stroke, and adequate BP control is also needed to prevent recurrence of stroke. I am thankful to Padma because she had covered some of my points about the hypertension control. Again, the hypertensive emergencies, hypertensive crisis is divided into hypertensive urgency and hypertensive emergency. And elevated BP without evidence of acute end organ damage is called hypertensive urgency, and with the end organ damage is called emergency. Of course, we are using malignant hypertension, accelerator hypertension. Now we don't use that. Malignant hypertension, we have papilledema, and accelerator hypertension, there is no papilledema. And this is the definition. When the blood pressure is more than 180, 120, with end organ damage, we call it as emergency. Without end organ damage, we call it as urgency. The questions to be answered are, what is the BP level at which one should start treatment? 180, 110, 120 and above? How quickly should blood pressure be reduced? What is the blood pressure target during this time of period? And how should this goal be achieved? Coming to the urgency, 1 in 100 outpatients used, you see hypertension urgency. We see 1 in 100 patients. Always use the correct technique. Let the patient sit in a quiet room and recheck the BP. And in 10 to 20% of the patients, the BP may come down. If there is a persistent high BP, it is preferred to admit the patient and observe. Of course, guideline says in hypertensive urgency, you don't need admission. Then these are the drugs when hypertensive urgency is there. We use oral drugs like clonidine, labetalol, and hydralazine. You always confirm urgency by serial blood pressure measurement and absence of end organ damage. Don't lower BP too rapidly or too slowly. Always remember, these patients are potential patients to go for emergency. So always prevent hypertensive emergency in urgency patient. Okay, now coming to the hypertensive crisis, especially in the neurology. Acute ischemic stroke, acute hemorrhagic stroke, and hypertensive encephalopathy. In ischemic stroke, elevated blood pressure is present in more than 80% of patients with acute ischemic stroke. Aggressive lowering of BP may lower cerebral perfusion pressure, thereby aggravating brain ischemia. Very high BP, on the other hand, can worsen cerebral edema, resulting in poorer outcomes. So, extreme hypertension can also lead to encephalopathy, cardiac complication, and renal insufficiency. Case fatality in acute ischemic stroke follows a U-shaped curve with regards to BP. Higher death rates at too low or too high BP. Best outcomes are observed at systolic blood pressure between 140 and 180. Now, what is the ideal antihypertensive drug? It should, especially parenteral antihypertensive, it should treat the underlying pathophysiology. It should be rapid onset of action, predictable dose response, minimal dose adjustments, highly selective, no increase in intracranial pressure, rapidly reversible, low risk of overshoot hypotension or adverse reaction, easy conversion to oral agents, acceptable to cost benefit ratio. Is there any drug like that? Unfortunately, we don't have a drug which satisfies all the above criteria. And these are the drugs normally used parenterally for acute hypertensive emergency, from the onset of action faster to slower. Start from the nitroprusside, esmolol, mentolamine, nitroglycerin, hydralazine, enoxaparin. So these drugs according to the so onset of action, we can give the actually sodium nitroprusside starts seconds to 2 to 5 minutes. Esmolol, a beta blocker, 60 seconds to 10 to 20 minutes. Now, the prior to receiving the RTPA, I'm thankful to Padma who has mentioned about these details. If the blood pressure is not maintained at or below 185, 110, do not administer RTPA. You must select the patient who are the candidates for RTPA, and when those patients have BP is more than 185, 110, bring the patient BP to 185, 110 before you administer RTPA. And management of blood pressure could be achieved using already Padma was talking, Lebetlol 10 to 20 milligram IV over 1 to 2 minutes, may repeat. Nicardipine 5 milligram IV titrate up by 2.5 milligram every 15 minutes and maximum 15 milligram. Of course, hydrazine and enalapril can be tried. During and after RTPA, what do you do? You must maintain the BP at or below 180 by 105. Monitor BP every 15 minutes for 2 hours from the start of RTPA therapy, then every 30 minutes for 6 hours, and then every hour for 16 hours. If the systolic blood pressure is more than 180 to 230, or diastolic blood pressure is more than 105 to 120, Lebetlol 10 milligram IV followed by continuous IV infusion 2 to 8 milligram per minute or nicardipine can be tried. If BP not controlled or diastolic BP is more than 140, we can consider IV sodium nitroprusside. But the problem is it can increase the intracranial tension. Ischemic stroke, avoid BP lowering in first few days unless the BP systolic blood pressure is more than 220 in population with large artery atherosclerosis or symptomatic stenosis. The current guidelines recommend a target BP of less than 180, 105 in patients treated with IV TPA. So after IV TPA, you maintain the BP 180 to 105. Data from the safe implementation of thrombolysis in stroke register suggests that systolic blood pressure of 141 by 141 to 150 might be the optimal after IV TPA therapy. In patients with successful recanalization, maybe immediate BP lowering might reduce the risk of symptomatic intracerebral hemorrhage. And this is the algorithm. When the patient qualifies for IV thrombolysis therapy, yes, you lower the BP to less than 185 to 110 before initiation of IV thrombolysis, and then maintain the BP 180, 105 for first 24 hours after IV thrombolysis. If the candidate is not suitable for thrombolysis and if the blood pressure is less than 220, 110, initiation or reinitiation treatment of hypertension within the first 48 to 72 hours after an acute ischemic stroke is not effective to prevent death or dependency. Pre-existing hypertension, reinitiate antihypertensive drugs after neurological stability. If the blood pressure is more than 220 by 110, lower the BP by 15% during the first 24 hours. Now coming to the hypertension and hemorrhagic stroke. Hypertension alone or along with other risk factors accounts for 80% of intracranial hemorrhage cases. The odds ratio for developing intracerebral hemorrhage in patients with hypertension is 3.7. The risk for developing intracerebral ICH increases with increased severity of hypertension. The hematoma expansion is more common in hypertensive intracerebral hemorrhage as compared to intracerebral hemorrhage due to cerebral amyloid angiopathy. So neurological deterioration is more common in patients with hematoma expansion. Cerebral edema and perihematomal edema are also more in patients with higher BPs. So higher BPs lead to higher death rates. BP lowering is the single most important predictor for better outcome in acute ICH. Intensive BP lowering is associated with better functional outcomes at 90 days after ICH. This is in contrast to ischemic stroke where BP lowering is avoided in the first 24 hours. For ICH patients with systolic blood pressure between 150 to 220 and without contraindication to acute BP treatment, acute lowering BP to 140 is safe. Some of the guidelines, recent guidelines says up to 150, 140 to 150. As Padma said, don't reduce below 140 and can be effective for improving functional outcome. For ICH patients presenting with systolic blood pressure more than 220, aggressive BP lowering with continuous IV infusion may be considered. Both nicardipine and lebetlol infusion are equally safe and effective. Patients with hypertensive ICH have a higher rate of recurrence of ICH, 9% at the 1 year level and 14% at 5 year level. So target BP of 130/80 or lower is recommended to prevent recurrence of stroke. There is no specific recommendation regarding the choice of antihypertensive agent and depends on age, comorbid conditions such as diabetes, renal insufficiency, cardiac disease, etc. The word about the hypertensive, encephalopathy. It's a encephalopathy. In contrast to stroke and trauma, the signs and symptoms of hypertensive encephalopathy may be headache, confusion, nausea, and vomiting. These symptoms usually abate after the blood pressure is lower. Dramatic improvement after BP reduction. Thus, patients with suspected hypertensive encephalopathy should have their blood pressure lowered by approximately 25% during the first hour, and additional lowering should be gradual, such that compared with the initial blood pressure upon presentation, the pressure is reduced by not more than 25% at the end of the first day of the treatment. And this is again algorithm. When you have ischemic stroke, when the patient is not a TPA candidate, treat the blood pressure, systolic blood pressure more than 220 or diastolic more than 120. If the patient is a candidate for TPA, reduce the blood pressure to 185 systolic and 110 diastolic and maintain 180/105. In acute intracerebral hemorrhage, BP more than 150 to 220, reduce to 140 and maintain between 140 to 150. The more important point is avoid BP variability. A word about subarachnoid hemorrhage, balance risk of rebleeding with risk of reducing cerebral perfusion pressure. And for acute ischemic stroke, nicardipine, labetalol, and treat when more than 220/120, except with thrombolytics like 185, 100. When you want to give thrombolysis, reduce to 185, 110, and then start. Excessive BP reduction may worsen. Intracranial hemorrhage, again, nicardipine, labetalol, as I said, reduce to 140 or maintain between 140, 150. Precipitous fall may produce problems. And subarachnoid hemorrhage, one drug which we use is nimodipine, apart from nicardipine and labetalol, and maintain the systolic blood pressure less than 160 and keep the systolic blood pressure around 130. Hypertensive encephalopathy, again, nicardine, labetalol, esomolol, and decrease mean arterial pressure 10 to 25% in first hour and 25% first day. Aggressive BP fall may produce ischemia. And BP control for primary stroke prevention. Target rate is less than 115/75 in less than 60 years. 140 less than 140/90 in people above 60 years. And when the BP is more than 160/100, it requires combination therapy. Nowadays, we always start with combination therapy. All the guidelines says any blood pressure, you start with a small dose of combination therapy and then continue. The latest studies, CCBs or ARBs were superior in stroke prevention. However, CCB is not favored in patients with heart failure. How do you control the secondary stroke prevention? The BP lowering with the target of less than 140/90, except in patients with severe bilateral carotid stenosis. In most studies, intensive BP management with the systolic blood pressure target of less than 120 has better outcome. Now, the drugs which you are used for secondary prevention, ACE inhibitor, triandropril, ramipril, then diuretic indapamide, ARB losartan, ARB telmisartan possibly effective, and then calcium channel blocker amlodipine is effective, but beta blocker atenolol is not effective. So I'll conclude. Hypertension is an important risk factor for both acute ischemic stroke and acute intracerebral hemorrhage. BP lowering is generally avoided in the first 24 hours in acute ischemic stroke. Target BP is 220/120 in non-thrombolized and 185 to 110 in thrombolized patients with acute ischemic stroke. In acute intracerebral hemorrhage, intensive BP lowering is beneficial. Target BP is always 140, around 140 to 150. Labetalol or nicardipine are the preferred agents. BP control is also important to reduce the future. The discovery, why blood pressure is very important. The discovery of the blood pressure was more important than the discovery of the blood itself, John Muller says. And this gentleman, Christian Bernard, says, I have saved lives of 150 people by transplant. If only I would have focused on controlling hypertension or preventing cardiology, I would have saved 150 millions. Ladies and gentlemen, please start hypertension specialty clinics, stop stroke units. In fact, Padma and myself were involved in starting so many stroke units. And I myself motivated more than 20 stroke units across the country. So I think you will have to also start the stroke unit. There are guidelines how to start a stroke unit, and you must focus on hypertension, prevent hypertension. Treatment adherence and follow-up in hypertension. Can we implement sincerely to improve control? Yes, we can. Once you control, you can control the blood pressure. So the Bhagavad Gita says, control over your regular exercise, time to relax. There's the right toil in discharge of his duties, observes proper hours of sleep and awakening, and is balanced in his actions and reactions, emotions and reasons, duties and rewards, can't cause disease. Ladies and gentlemen, my final message is learning is the beginning of health, learning is beginning of wealth, learning is beginning of spirituality. So ladies and gentlemen, let us know and understand how we can manage stroke under emergencies, and then focus on hypertension clinic, focus on home blood pressure monitoring, and start stroke unit. Thank you for the opportunity. Over to you, Maheshwari.
Thank you, sir. You are the master of hypertension, and I welcome you, sir. Many times you are advocating that hypertension clinic should be there so as to reduce the morbidity in heart as well as in the brain. Thank you, sir. Kindly stay till the question hour is there.
Yeah, but
May
one
I request-
message on behalf of Padma. We had been starting and focusing and motivating physicians to start stroke units. So many people have started stroke unit, and I think my brother Shashank has come, and he will also agree the prevention is better than treating stroke. So preventing stroke is best by controlling blood pressure, of course, controlling diabetes also. I think Shashank will agree in his presentation. Thank you. Over.
Thank you, sir. May I request Dr. Shashank Joshi, he will deliver management of blood sugar in stroke. He is consultant endocrinologist in Leelavati and Bhatia Hospital and Joshi Clinic. He has been awarded International Clinician Award 2012 by the American College of Endocrinology. He has been conferred Padam Shri by President of India in 2014. He is President of Indian Academy of Diabetes, past President of Endocrine Society of India. He is past President in API 2014 to 2015, past President of RSSDI. Now over to Dr. Joshi, sir.
Thank you, Dr. Maheshwari. At the onset, I would like to agree with Dr. Muruganathan. In fact, 1997, I joined Leelavati Hospital, and the late Dr. P.M. Dalal already had a stroke unit in the hospital. It was the first hospital to have a stroke unit and a stroke as a specialty. And they had his student, Dr. Shirish Hastak, used to work with him that time in the stroke unit. So we have been involved in that stroke research since then. It is such a delight, Dr. P.K. Maheshwari and Dr. Gagan's team. The entire neurology team is here. I can see my good friend, Dr. Rajinder Bansal, and my, various other members from the fraternity, Dr. Surya, Nirmal Surya, Dr. Padma, everybody. And of course, I can see my API colleagues, Dr. Jyotirmay Paul, our dean, Dr. Muruganathan, my brother, Dr. Girish Mathur, and the entire API fraternity. So I'm going to now move gears from, hypertension to diabetes. And my apologies that I got a little delayed. Am I audible, Dr. Maheshwari, and are my slides visible?
Very well.
Yes,
very well.
yes, yes.
So I'm going to have a very crisp talk on how to manage optimal blood sugar levels in acute stroke. I mean, that's the mandate to me. So some background, and then, glycemic management during acute stroke, because that's what I thought I will highlight, because it's difficult to highlight too many things. So we all know that there is a huge economic and social burden of stroke. More than 14 million people worldwide suffer from stroke every year. 3 to 4% of healthcare expenditure in Western countries is spent on stroke. The annual cost of stroke in the US alone is $45 billion US. And we all know that 1/3 die, 1/3 recover, and 1/3 are permanently disabled. We also know that strokes significantly deteriorate functioning and quality of life. And most survivors need long-term rehabilitation. And half the stroke survivors require permanent or temporary care. So what's the data set in evidence-based era today of prevalence of diabetes in people with stroke? And a meta-analysis of 39 publications with more than 359,000 patients shows that around 1/4, the prevalence of diabetes in stroke patients is around 28%. So 1/3 of 1/4. Prevalence of diabetes in people with ischemic stroke is 33%. And prevalence of diabetes with people with hemorrhagic stroke is around 24%. So that's the current database. We clearly know that if you have presence of diabetes or dysglycemia, it increases risk of stroke, because we all know that type 2 diabetes is a vascular disease. It's an endothelial dysfunction with microvascular and macrovascular changes. And these changes often culminate into clinical complications, and stroke is one of them. So diabetes is a modifiable risk factor for stroke, and people with type 2 diabetes are more likely to have a stroke at a younger age, and they have worse outcomes. So if you ask a question, what is the hazard ratio of having ischemic stroke with people with diabetes type 2 without and people without type 2 diabetes, is 2.27. So clearly type 2 diabetes is an independent risk factor for stroke recurrence as well. So it's not just development of stroke, but also for stroke recurrence, the hazard ratio is 1.45. What are the mechanisms by which type 2 diabetes leads to stroke? Well, as I told you, it's vascular endothelial dysfunction, nitric oxide mediated vasodilation, which impairs in type 2 diabetes, that leads to endothelial dysfunction and triggers atherosclerosis. Systemic inflammation, you know that the atherosclerotic plaques are very inflamed, and we also know that the arteries are very stiff, and the stiffer arteries and decreased elasticity is very classical and typical of the Indian phenotype with diabetes, and that really predicts them to getting stroke. In addition to that, if there is obesity, hypertension, and dyslipidemia, it's a quadruple whammy. So, when you look at people with stroke and diabetes type 2 or compared to those without, when you look at registry, clearly people with type 2 diabetes are younger. They are more often in ethnic minority, and Asian Indians are no exceptions, and they have higher BMI. So these people, younger people, and our ethnicities clearly have a predilection. We also have some medical history characteristics which are more common in people with type 2 diabetes who get stroke, like hypertension, chronic kidney disease, dyslipidemia, coronary artery disease with prior MI, prior stroke or TIA, carotid stenosis, PVD, and heart failure. So, what are the outcome differences with stroke with type 2 diabetes compared to those without diabetes? And clearly the US data is very clear cut that poorer outcomes are seen in people with type 2 diabetes than without. There's a higher mortality rate. So the all-cause mortality hazard ratio is 1.24, and the readmission rate and recurrence rate is higher. So readmission of ischemic stroke hazard ratio is 1.2. So this is a large US registry from which this data set is taken. So clearly stroke patterns in people with type 2 diabetes, there's an increased likelihood of limb weakness, dysarthria, and lacunar cerebral infarcts. That is very typical. And also in type 2 diabetes, there is a predilection for cerebral small vessel disease among the other stroke subtypes. Also, what is now increasingly being recognized is the poor cognitive outcomes in people with stroke and type 2 diabetes. And clearly the poor neurological and functional outcomes after stroke is now globally recognized. We know the global cognition and all domains are affected in people with diabetes, whether it's executive function, perceptual motor function, attention or processing speed, memory or language. All of them are clearly impacted. So what happens when glucose goes up? Well, when people get ischemic stroke and when there's acute hyperglycemia, there are three things which happen, which we should all know. And this is my first take-home message for today. There is increased brain lactate production, decreased salvage of the penumbral tissue, and there is a final infarct size, or the net infarct size goes up. So clearly higher glucose aggravates strokes through an augmented reperfusion injury. So that data is pretty clear cut now. And we clearly recognize this for at least a decade now. And we clearly know that when there is oxidative stress during reperfusion, there is exaggeration of systemic inflammation, and there is a increased permeability of the barrier permeability. So this is why you need to understand that whenever we get high glucose levels during acute stroke, the brain lactate goes up, the penumbral tissue salvage becomes tougher, and the net final infarct size is larger. And there is a lot of augmented reperfusion injury with a lot of inflammation and leak. Clearly, when there is hemorrhagic stroke in people, when the glucose goes up, the outcomes are clearly poorer, because we all know that there is an exacerbation of hematoma expansion and perihematoma edema. So clearly, when there is hyperglycemia in hemorrhagic stroke, it leads to a sympathetic activation as well as an induction of hormonal and metabolic alterations. And those lead to systemic complications due to elevation of CSF levels and urinary catecholamines. So clearly, you can see a sympathetic discharge, which is hurtful or harmful, which we recognize very clearly. So this was the initial part about the background. But how should we manage glucose in acute stroke? And that's something which we need to recognize. Now, there's a lot of data which recognizes that we have found a lot of variability. And we can measure variability with the advent of continuous glucose monitors now, with stroke onset. And these glucose fluctuations, or GV, is an independent risk factor for poor outcome as well as glucose levels. We clearly now recognize that hypoglycemia can cause focal neurological deficit. Severe hypoglycemia alone can cause neuronal injury. And hyperglycemia with glucose above 126 is common in people with acute stroke and is a poorer functional outcome. So getting the glucose levels right is crucial without hypoglycemia and without hyperglycemia. So the peaks and valleys need to be blunted out. And therefore, it is mandatory to do glucose check and rapidly correct both high and low serum glucose at the first given opportunity which a clinician gets. So when we evaluate glycemic levels in stroke, if a person presents with hyperglycemia and acute stroke, and person has a pre-existing diabetes mellitus, and there are other risk factors like hypertension, dyslipidemia, retinopathy, neuropathy, and peripheral vascular disease, that's one set of patients. And there is another set of patients which present with hypoglycemia and stroke-like symptoms, which is also not uncommon. In individuals present with low glycemic levels and stroke-like symptoms, diabetes may have been diagnosed earlier. There could be hypoglycemic agents like secretagogues or sulfonylureas or repaglinide or insulin, which may be instituted. And signs of acute stroke like hemiplegia, aphasia, cortical blindness also have been reported with hypoglycemia. So we need to recognize that when you see acute stroke, you can get hyperglycemia with all the comorbidities around diabetes, or you could get hypoglycemia with its conundrum. So how do we treat? What are our treating strategies? Dr. Padma gave us a very nice illustration. Preserving the ischemic penumbra through recanalization of the occluded artery by means of TP or mechanical thrombectomy, maintaining adequate cerebral perfusion, optimizing medical management, general supportive care, and preventing associated complications. But crucial in outcomes for all this is early recognition of hyperglycemia as well as optimal patient outcomes, both by managing hyperglycemia, by hitting hard, hitting early, tight glycemic control. Whether it is the American Heart Association, American Stroke Association, the European Stroke Organization, their goals are very clear. There are no consensus in guidelines on management of hyperglycemia and stroke globally. But what everybody says is achieving tight glycemic control with insulin is recommended, and normalization of glucose in the first 48 hours of hospitalization is associated with survival benefits. So that data by Gilead and Miller in stroke published almost 5 years back is pretty clear cut. The Europeans say, again, tight glycemic control with insulin as a means to improve outcome is not recommended. So you can see how the European and Americans are, contrary to their guidelines. And hyperglycemia in acute stroke patients should be treated similarly, regardless of the presence of type 2 diabetes. So I think what is prudent to understand for us when I give you two such divergent guidelines is that try to keep your glucose without hypoglycemia. So try to keep your glucose between 80 and 120. Or if you want to have a larger window, 100 and 140. And if you still want to have a larger window, between 140 and 180. So these are the three windows in which, because there is no outcome data and there is no consensus on the guidelines, insulin is a reasonable means, but as long as you are able to avoid hypoglycemia and you are able to train your nursing staff and your critical care staff to manage glucose well, I don't see a challenge about the agent which we use. So in a hospital setting, usually insulin is recommended and oral agents are generally not recommended. This is changing very fast with the advent of gliptins and newer drugs which are quite good and very effective. So IV insulin is usually seen in ICU and critically ill patients, and subcutaneous insulin is seen normally in non-critical patients. Try to keep your glucose between 140 and 180. So how does one do that? Well, I think it's pretty straightforward. Usually the total daily dose of insulin for basal bolus calculated as 0.4 to 0.5 units per kg for the ideal body weight. If somebody is obese, which means the BMI is about 30, then try to give a little higher dose, maybe 0.5 to 0.6. And somebody is lean or renally compromised, give it at 0.3 to 0.4 units per kg. So the calculation of total dose is pretty straightforward and simple. calculate the total dose and divide that total dose into 50% bolus, 50% basal. Try to give the bolus dose equally between 3 large meals if the patient is having oral feeds. Measure blood glucose 3 times pre-meals and 1 time at bedtime. Try to measure the insulin sensitivity if it is possible. It's quite easy to understand it. Sometimes you need a correctional bolus, particularly if the IV fluids and other agents going on. And titrate fasting glucose with basal insulin. So you give a basal insulin and try to give bolus insulin. That's the standard of care. If somebody is insulin sensitive, then there is a correction protocol. And this is published. This is an Indian clinical practice guidance. You can see here very clearly in an insulin sensitive individual, 0 to 100 to 140. You don't need anything. 140 to 180, 2 units in a sensitive individual, 6 units in a resistant individual. Usual care is 4. And these are the protocols which you can use. And you can see that you need to understand that people who are sensitive and people who are resistant need a differential. And it's important to recognize and pick them up in clinical practice. Well, when there is extreme or persistent hyperglycemia in critically ill, or those who are needing or treating thrombolytic therapy, they should be started on an established standardized IV insulin protocol where the nursing team is trained to improve blood glucose levels for the first 24 to 48 hours. And they should be transitioned into subcutaneous insulin and basal bolus insulin with whenever the glucose is out of range. Lot of these protocols are available. We at RSHDI, myself and Dr. Panikar, who works with me at Lilavati, we have developed such protocols. But the primum non nocere, which means first of all, do no harm, is avoidance of hypoglycemia, education of nursing staff and resident doctors. And the standard protocols which have been used are the Portland protocol, the Lewin protocol, the Yale protocol, the CUP algorithm, the GANS protocol, the RBH algorithm. We also have our RSHDI protocol, which we had developed from the Lilavati protocol. And we have an app on it. It's pretty straightforward, but it's all about education. So the idea is to keep the glucose under good control. The exact protocol is probably less important. What is important is the presence of an institution and adapting the staff taking care of the person with stroke and diabetes to meet the individual hospital needs. So first step in the algorithm, and remember, if the person is type 1 diabetic, somebody is diabetic ketoacidosis, or somebody has hyperglycemic hyperosmolar state, then you need a separate protocol altogether. So in an insulin protocol, first step is standard drip, 100 units per 100 ml with the normal saline, and use an approved IV insulin, whether it's regular, aspart, glulysin, fast acting, it doesn't matter. They're all the same. In IV, everything works the same. And step 2 is that if the glucose is above target, start the insulin. And if it is below target, take off the insulin. People with no history of diabetes and are receiving less than 1 unit per hour, or patients who receive the first subcutaneous basal and bridging dose, you need to be a little cautious. And therefore, first of all, do no harm. Then, start the bolus dose, initiate the infusion rate, divide the initial glucose by 100, and then round it to the nearest 0.5 for the bolus. So if the initial glucose is 174, divide 174 by 100, which becomes 1.74, round it off to 1.5, give IV bolus 1.5, start the infusion 1.5 unit per hour. The next step is IV fluids. Most patients will need 5 to 10 gram glucose per hour in D5 or D5 half normal saline at 100 to 200 milliliter per hour, or an equivalent of enteral or TPN feed. And then sort of make into an algorithm. And then look at whether there is a underlying CABG, organ transplant, steroid use, or they are needing a lot of insulin dose. So there are 2 algorithms, algorithm 1 and algorithm 2. I'll be happy to share these slides with the organizers. If anybody wants them, they can use any of these standard algorithms. These are pretty straightforward. For brevity of time, I'm rushing through it, but try to keep it simple. Because the point of care monitoring of blood glucose in critically ill inpatients is very crucial. Initial estimation of 1 hourly interval, check every 2 hours for 3 consecutive readings. If there is a fall, discontinue it, and then periodically keep testing and appropriate it. So remember that management of hyperglycemia is not rocket science. You just need to monitor glucose more frequently to prevent hypoglycemia and change the doses of medications which are needed. Whenever hypoglycemia is discovered, glucose must be brought expeditiously to normal level. We can use IV fluids like D5, 25 dextrose or 50% dextrose sometimes. Remember that dextrose 5% is not an appropriate fluid because excess of free water may exacerbate cerebral edema. And because hyperglycemia may be induced, the harmful effects may sometimes be seen. So you need to be a little more cautious when you use that. Nurses play probably a key role, and it's all multidisciplinary effort. So it's all about nursing, pharmacy, nutrition support, endocrine specialists, because you can get a lot of brittle diabetes. And in the acute period, all patients should have a regular glucose monitoring, ideally every 2 hours, if not at least 4 to 6 hours, particularly if they're NBM or they are on continuous tube feeds, with meals and at night. Monitor glucose every 1 to 2 hours in people who need insulin infusion. Nurses play a pivotal role in detecting hypoglycemia, and we now have the availability of CGMs. In COVID times, we did use the CGMs, but remember they measure interstitial fluid. And sometimes in acute stroke situations, they may not be as accurate as capillary glucose measurements. And you need to ensure that the nurses, the resident doctors, as well as the attending physicians need to have a very good coordination and need to have properly driven protocols. Don't use sliding scales. It's very important to recognize that when you transit from insulin infusion to subcutaneous, start slow. If it's a type 1 patient or a type 2 diabetic patient, they need subcutaneous basal insulin 2 to 4 hours before the infusion is discontinued. So you need to often give the dose almost 2 to 4 hours before. You need to also give a correctional bolus dose for nutritional and correctional doses in those who are having oral intake or taking enteral nutrition supplement formulas. But people who are NBM or we have poor oral intake, you need to be a little more cautious where a basal plus or basal bolus regimen is preferred. Education is the key. And later on, you need to teach patients and family members, particularly during the rehab process. Because remember, in strokes, you need to get good glucose control with the least glycemic variability, because there is a direct correlation and hazard ratio between recurrent strokes. So the key points to address during hospitalizations with a new or a chronic diagnosis of diabetes is medications, lab studies like A1C, discuss the goals, talk to the nutritionist, ensure that the person can manage self-care better or has an assistant to manage it, and proper communication, particularly at outpatient, on discharge summary is the key. So summarizing, I think acute stroke has a lot of complex challenges. They need to be handled timely and discreetly and efficiently. Treating glucose is very challenging, and if not managed early following a stroke, you can have negative impact on patient outcomes. Insulin is not sacrosanct, though is preferred by the Americans and not preferred by Europeans. But most of us still prefer insulin, in at least India. Glycemic control without hypoglycemia is the key, and that needs a lot of collaborative efforts of the medical team and support staff. And that's really the key, the support staff. Thank you for the opportunity. And I'm sure that there may be a lot of questions which I'll be happy to join during the panel discussion. And I'm grateful to Dr. Maheshwari for pushing me hard to be here. Thank you so much.
Thank you, sir. With your extensive, elaborative teaching to all of us, and also message to the society about the blood sugar, low or high, how do you manage, and what the words say, what the global says, what the Shashank Joshi says. Thank you, sir. Again, still Dr. Wander is in the flight, not landed up. So we're starting with panel discussion, and a lot of the questions are there, specific to the specific panelist. And first of all, I'll take up with Dr. Kameshwar Prasad, who is Professor of Neurology and Director, Rajendra Institute of Medical Sciences, Ranchi, India. Already he was, just before that, he was Professor and Head of Neurology Department and Chief of Neurosciences Center, New Delhi, AIIMS. And his area of interest is a stroke, meningitis, multiple sclerosis, research methodology guidelines, and a lot of the good sense about what the law says, what stroke says, what the guideline says. He has got 375 papers, and he has been awarded Padam Shri by the Honorable President of India. And may I request Dr. Kameshwar Prasad to share your things in the management of intracerebral hemorrhage, and also what a word about how do you prevent the deep vein thrombosis or pulmonary thromboembolism in the intracerebral hemorrhage? About intracerebral hemorrhage, sir. That is also one of the 15 or 20% part of the stroke.
Thank you, Dr. Maheshwari. It's a pleasure to attend such a well-attended, I think, IN API stroke seminar or webinar. And I think already a lot of important points have been covered. You asked me about the intracerebral hemorrhage.
Yes.
Most important thing is that diagnosis of intracerebral hemorrhage has to be done with a CT scan. And I'm saying this very carefully and excluding MRI, in spite of the fact that there are papers which say that MRI is as good as CT scan for two reasons. One is I have seen expert neuroradiologists missing subarachnoid hemorrhage in MRI brain, which was picked up by CT scan. Second, CT scan is so easily available and so clear in diagnosis of intracranial hemorrhage, whether it is subarachnoid or intracerebral, that I think this should be preferred over MRI as far as diagnosis is concerned. Once diagnosis is made, then I would suggest that physicians should classify their patients. Patients who are likely to require surgery, or they are very sick patients, or patients who are stable, unlikely to require surgery, which means medical management will be enough. How to classify those patients? I would tell them that just look at the level of sensorium, and in the CT scan, calculate the volume of hematoma. If sensorium is altered, be very cautious. He is very sick patient. May even require surgery, because you know that hematoma grows in first 24 hours in 30% of patients. So the patients who are conscious, alert, have a small hematoma, let's say less than 20 ml volume of hematoma. And volume calculation is easy. We say ABC by 2. A is the biggest diameter, B is the transverse or perpendicular to that diameter, and C is the number of slices in which this hematoma is seen, and you see the millimeter thickness of the slice, then multiply, divide it by 2, you get hematoma volume. If volume is 20 ml or less, manage only the blood pressure. Don't worry too much about other things. I see a lot of patients receiving 101 drugs, but basically what is required is control of blood pressure, control of any other risk factor which might be there, and monitoring of blood pressure. As I won't go into details of how to manage it. I think already Dr. Magandhan has already highlighted this. But most important point is, the second thing is, if patient has plegia, means paralysis of limbs, particularly lower limb, then you need to prevent deep venous thrombosis. And people may be tempted to use what I would call a dangerous choice, which is heparin. Heparin should not be used in intracerebral hemorrhage. Even if you read papers which say that, no, heparin use is safe. I have used in 20 patients or 30 patients, nothing happened. It is not good enough. What is to be done? Do three things. One is start physiotherapy very early. Second, use DVT pump. If you have available DVT pump. And third thing is keep hydration, very good hydration, so that patients are unlikely or less likely to develop thrombosis. These are the things to be done if patient has lower limb paralysis to prevent deep venous thrombosis. Now, patients who are sick and likely to require surgery, you have to monitor very closely. Maybe you have to repeat CT scan even twice a day at times. And then you have to plan a consultation with neurosurgeon and see when surgery is required. But while preparing for surgery, a patient has altered sensorium, start mannitol. That is where mannitol is required. I hate to see mannitol being started right, left, and center in every patient, and then 101 medicines unnecessarily. The patients who are sick are also likely to develop acute GI bleed, and therefore you have to give some preventive measures for preventing GI bleed, whether you use proton pump inhibitors or in what your institution, whatever is practiced, maybe ST receptor blocker or whatever. And third thing is, many of these patients are likely to aspirate and develop aspiration pneumonia. Watch out for fever and use antibiotics as soon as you find fever, even though sometimes you may have difficulty in locating the site of infection. So if surgery is required, then you have to hand over to neurosurgeons. Of course, neurosurgeons won't operate unless blood pressure is under control. So use the drugs which have been mentioned and refer to neurosurgeon for surgery. Now, people will say when not to do surgery, even in sick patients. That is a very difficult question, but I always tell people, what's the age of the patient and what does family want? So even after surgery in a person who is 80 years old or above, and large hematoma, more than 30-40 ml of hematoma, altered sensorium, patient is very unlikely to get out of bed. So my question to family members is, if you think surviving while lying still in bed is what is desired by you, then we will go ahead and do surgery. Most of the time, even educated or even uneducated people say that very old patients, large intracerebral hemorrhage, just give tender loving care and don't subject every patient to surgery. I think this is in a nutshell what I would say is the treatment of intracerebral hemorrhage. I did not go into subarachnoid hemorrhage. That's a different ball game, and I will like to avoid in the interest of time.
Sir, I have one question. Suppose the patient with intracerebral hemorrhage have already developed DVT, then what will be your drug of choice? How will you treat?
Well, I think that is a very difficult situation. First thing you have to assess is whether he is at risk of thromboembolism. And in extreme cases, we have to use inferior vena cava filter to prevent venous thromboembolism. But if 7 days have passed, patient is stable, and you think there is no availability of vena cava filter, I think that is the stage when you are safe enough to start using low molecular weight heparin. Maybe, as you know, we use for prevention only once a day. I will start therapeutic dose is twice a day, but I will start once a day. Watch out if there is any increase in hemorrhage. Probably it will be safe. Then I will double the dose after a couple of days.
Is there a role of NOAC?
This is something which I am telling you not based on evidence, but this is what I would practice.
Sir, is there a role of NOAC in the case of DVT with intracerebral hemorrhage?
No, not enough evidence to say one way or the other.
Yes.
I think more studies will be required.
Okay.
Thank you, sir. But my one query is that when a stroke is there, how much time required to get the first CT scan so as to distinguish in between hemorrhage and the ischemic stroke?
Earlier, the better. Do it within half an hour if possible. Because, you know, if it is ischemic stroke, you have to line up many other things depending on the, criteria the patient meets. So it is important to diagnose whether the stroke is ischemic or hemorrhagic right at the outset. Why wait even half an hour if you have availability? You do it earlier than that. But I think the quality criterion of any center having good stroke care would be if CT scan is done within half an hour.
Thank you, sir. Good message about hemorrhage. Yeah.
Sorry?
Dr. Subhash Kaul.
Sir,
Sir.
can I ask one question to Professor Kamesha Prasad, sir? Am I
Yes,
allowed?
sir.
Sir,
course.
good evening, sir. Good evening, Dr. Prasad.
Good
Sir,
evening.
one of the common problems which occurs is that when a patient is a disabled stroke who can never walk again, and he is taken to home and he's bedridden forever. So the question is that how long we give them low molecular weight heparin or oral anticoagulants, because there are no guidelines on that. So what would be your advice for this kind of patients?
No, if patient is likely to remain bedridden, the high risk period for development of deep venous thrombosis is only the initial 3 to 4 weeks. After that, I think there are no major studies to say how many people develop deep venous thrombosis after 3 weeks of or 6 weeks of acute stroke. But I think that is a decision which you have to take when to discontinue heparin.
Yeah.
I would discontinue in maybe 6 weeks time, and then more depend on the physiotherapy, mobilization, other kinds of keeping hydration and so on. But this will vary from physician to physician.
Thank you.
Thank you, sir, for the query. Now
Thank
the
you.
next query
yes.
for Dr. Subhash Paul.
Okay.
He is senior consultant neurologist in Krishna Institute, Secunderabad, former professor and head department of neurology and dean NIMS, Hyderabad. He is already the past president of Indian Stroke Association and past president of Indian Academy of Neurology, and a lot of the publication with his hand, and he's very well recognized and internationally and nationally, Dr. Kaul, in the stroke. And Dr. Kaul, the query is how do you choose antiplatelet regime for stroke prevention? And second query is, when do you restart antiplatelets, anticoagulants after intracerebral hemorrhage? First query is, how do you choose antiplatelet regime for the stroke prevention?
Yes, sir. So I think we are here talking about secondary stroke prevention, means because for primary stroke prevention, antiplatelet agent is not usually used. So we are talking of secondary stroke.
Secondary.
So the first of all we have to do is differentiate the stroke into cardioembolic or non-cardioembolic while the patient is in the hospital. So if it's a cardioembolic stroke, obviously we have to give them oral anticoagulant. Now, if it's a non-cardioembolic stroke, then we have got choice of antiplatelet drugs, and the clear choice, number one choice, is aspirin. And for secondary prevention, 75 milligram is good enough. And I think there are excellent guidelines by Dr. Prasad, Padma, and the group, which are on the website. I have also seen it so many times. So for all strokes, if you take aspirin for secondary prevention, 75 milligram is good enough. That we should remember, that is the established king of all antiplatelets. No question about it. Now, in a subset of strokes, you can give double antiplatelets. Now, which are these subset of strokes? These are either TIAs or minor strokes. Now, minor stroke means that who has just a mild neurological deficit. In neurology, we use a scale called NIHSS, which is easily available, on the website, and you have a lot of apps on that, and you can easily find it. And if the NIHSS score is 3 or less than 3, which basically means that patient has just a mild hemiparesis, then you can give them dual antiplatelets, and the dual antiplatelet which has been tested is aspirin plus clopidogrel. And on the first day, you can give a loading dose of clopidogrel, that means 4 tablets, 300 mg, plus aspirin anyway the patient will be on. And then you can continue, from the second day, you can give 75 milligram both, and you can continue them for 3 weeks. But after 3 weeks, we must go back to a single antiplatelet, which is usually aspirin. Because there is one issue with clopidogrel is that about 30% of the people may have resistance to that. So on a long term, it's always better to give aspirin. But this 3-week thing is very important, because many times physicians forget and they continue to use dual antiplatelets, and then they may land up in hemorrhage and all. And while this dual antiplatelet is going on, it's very important that the patient should keep his blood pressure and all under control, so that there is no risk of any pain. Now there is one if the patient is investigated completely they have got a MR angiogram and they find that there is a very tight or very atherosclerotic artery in the brain which caused the stroke. In that case, you may extend the double antiplatelet to 3 months. But usually, by and large, 3 weeks recommendation is there. And I think once again, it is in the Government of India advisory. And I think Dr. Prasad has done a meta-analysis. So 3 weeks we must do, in some cases for 3 months. Now, only one more addition I want to say that recently, in the last few months, we also have got the addition of ticagrelor, which is a very favorite antiplatelet drug among cardiologists. That also we can give in some patients who are allergic to clopidogrel or who have failed clopidogrel earlier on. That also is an option, but that should be given only for 1 month if you are using double antiplatelets, and that should, and the aspirin dose in that should never exceed more than 100 mg, and in our case it will be 70. So that is how you would use the double antiplatelets, and that will be my choice. Now, your second question, sir, can you repeat that?
Anticoagulant. Anticoagulant.
No. What is the full question? What is the full
After a bleed, when do you resume antiplatelets or anticoagulants?
Yeah, I think this is an excellent question. Now let us imagine there's a patient who has a intracerebral hemorrhage. Now, after the intracerebral hemorrhage, when do we start antiplatelets? Let us talk first about the antiplatelets. Obviously, this will be a patient who is having a non-cardioembolic source for his essential original ischemic stroke. So when do we start? And there are some large studies which have been done abroad. And the answer to this is, which is quite established, and it's in the American Heart Association website, that you can start antiplatelet in these patients from between 4 to 8 weeks. Actually, no, for antiplatelet, you can start from the first week onwards. The studies have shown that you can start antiplatelets from first week to 7 or 8 weeks. But it is safe to start them from first week onwards. But you would also, now this is a big range from the study between 1 week to 8 weeks. So how would you decide? You would decide on two things. One is that what is the etiology of the brain hemorrhage, and what is the embolic potential of the, for which you are using antiplatelet. For instance, if the patient is having a lobar bleed, which is because of amyloid angiopathy, then you might wait for 2 weeks or 3 weeks. On the other hand, if it is a simple because of hypertension, then you can give it even at 1 week. And so you can balance that. How is the bleed in the brain and how is the embolic potential? You can bleed. But by and large, it's thought, the studies have shown that they usually do not cause any increase in the brain hemorrhage, and you are good enough to start them at 1 week. That is as far as the antiplatelet is concerned. As far as anticoagulant is concerned, there you have to be a little more careful. And in case of anticoagulants, once again, you have to look at the type of brain hemorrhage also, and you have to look at the cardiac, embolic potential also. Now, let us talk about a typical antihypertensive hemorrhage. And in the case of antihypertensive hemorrhage, if you take, you can, by and large, it is said that you should start them at 6 weeks. You should wait for 6 weeks, although in practice people are giving at 2 weeks, but it is said that it is safer to start them at 6 weeks, right? But one more thing, you have to see that what is the underlying cause for which you are giving oral anticoagulants. If there is a mechanical heart valve, this is at a very high risk of embolization to the brain and getting stuck valve and all. This is the only situation where you are allowed to start oral anticoagulants at 1 week only, as early as 1 week. In fact, it's clearly mentioned that in these patients, even though the patient is having a brain hemorrhage, you should give them intravenous heparin from 3rd day onwards, even though there is a brain hemorrhage. And then after 7 days, you should switch that intravenous heparin to oral anticoagulant. So by and large, in brain hemorrhages, it is safe to start oral anticoagulants after 6 weeks, with the one exception, that is the mechanical valve, where you can give it at first week itself.
There is one related question. It says, you have a hemorrhagic infarct. So is it, do we continue antiplatelets or do we give antiplatelets?
No, it depends on, some kind of hemorrhage happens in all infarcts. If you microscopically look, there is some kind of ooze in all the infarcts. So it is not such a big deal. Probably in case of hemorrhagic infarct, I would just wait for another 1 week, but not more than that.
Sir, I have one question. Suppose patient has come with infarction and underlying heart condition has atrial fibrillation.
Yeah.
So after the day one, you will start the oral anticoagulant, or we will wait for the few days to avoid the hemorrhagic conversion?
No, oh, so you are saying patient is having an infarct.
Infarct at the same
Yeah.
time atrial fibrillation.
Yeah.
The day one, you will start anticoagulant, or we will wait for
Not day one. I think Padma made a reference to that when she was giving a lecture. You have to, it will depend upon the size of the infarct. How big is the infarct? If the patient is having only TIA, you can start on day 0. If the infarct is less than 1/3, means it is small, you can start on day 3. If the infarct is 1/3 of the MCA, you will start, then you will start at 1 week. So depending upon the size of the infarct, you can start on day 0, day 3, day 7, or day 14.
Yes.
It will depend on the size of the infarct.
Sajam, very excellent, excellent.
Thank you, sir.
Thank you, sir. Thank you, sir.
Only stay with till the question, because a lot of the questions are there in the question.
There is one, Dr. Maheshwari, sorry to interrupt you. There's one question for Dr. Shashank Joshi. How to check insulin sensitivity in stroke emergency?
Dr. Joshi, sir.
Right. So, or maybe you can continue, and once he's back, you can ask that question.
Yeah. Now, next, our panelist is Dr. Silaja. She is professor and head of the neurology in Sri Chitra. She is also in charge of the comprehensive stroke program. She is also the past president of Indian Stroke Association and very good CME convener of the Indian Academy of Neurology at present. And requirement from some audiences there, that what are the essential requirements for a stroke unit and its role in overall stroke management. Essential requirement for a stroke unit and its role in overall stroke management.
Thank you, sir. Thank you, Dr. Maheshwari, for the invitation to be a part of the panel, and thanks to the IAN and the API for this invitation. Stroke unit, I think we already have a very good discussion on the stroke unit and its essential parts. The first important thing we should understand is that it is already known from enough evidence that managing patients in stroke unit compared to a general medical ward definitely improves the outcome. It reduces the mortality and reduces the morbidity too. About coming to the stroke unit, so how does a stroke unit reduce these morbidity and also the mortality? It is mostly with regard to how it's done is mostly how you prevent the medical complications. Because with the stroke units, we know that the management of the preventing the aspiration, preventing the deep venous thrombosis, very good monitoring of these patients by preventing the hypoxemia, hyperglycemia, controlling the hypertension adequately. All these are very, very important in the stroke unit. So how does this happen so if you look at the essential parts of the stroke unit, any designated area in a hospital, you can designate as a stroke unit. It's only important that it's only the stroke patients needs to be admitted there. For example, you maintain a stroke unit and you should not have other neurology patients also coming in. How it's important is the stroke unit should be managed by a specialized team. The specialized team in the sense that it should be a team which involves the most important part is a neurologist or the physician who is the integral part. And the next most important part is the nurses. You should have a very good nursing team who is well versed with monitoring of the neurological and the medical monitoring of these patients, and a multidisciplinary team which involves a very good rehab team. At least a physiotherapist and a speech therapist should be an integral part of the stroke unit. So how should be the stroke unit with regard to the monitoring? You should have at least a monitoring where you should have a neurological and medical monitoring where the blood pressure, blood sugar, all these can be monitored. Secondly, there should be facilities in which Patient's neurological assessment should be possible. So you should have the facilities where the neurologist and the nurses are trained with regard to assessing the NIHS in these patients, because that is the only way we will know there is a worsening of the patient, because at the admission and whether the patient is fluctuating or worsening. And we should have the monitoring facilities available for the in these patients. So which kind of patients needs to be admitted in a stroke unit is the another important aspect. All hyperacute patients with stroke, that is in the first 24 to 48 hours, needs to be admitted in a stroke unit. Following that, even you can admit patients up to 1 week or up to 2 weeks, where the patients are really sick patients or the patients who are fluctuating and worsening. These patients also need admission in a stroke unit. So the stroke unit can be of different types. It can be if you look at the requirement part, it can be a primary stroke care unit, these are the stroke units which usually you keep in the district hospitals or smaller hospitals, where the requirement is you have this nursing with the physician and the rehab team, and you should have facilities for a 24-hour CT scan should be available, and MRI is not mandatory, and if possible, a vascular imaging is possible. And also it should have facilities for giving intravenous thrombolysis. So these facilities should be available to call it a primary stroke care unit. But compared to that, a comprehensive stroke unit is should have additionally. So if you are thinking about a comprehensive stroke care unit, you need to have a more bigger team, which involves interventional radiologist and a big team of neurosurgeons and others should also be available. So the extra things which needs to be there in a comprehensive care unit is you should have facilities for advanced imaging, both vascular imaging and perfusion imaging, because you are going to treat more late window patients or patients who are beyond the window period, and you need vascular imaging because you need to decide on endovascular thrombectomy in these patients. Also, in the comprehensive stroke care unit, it should be more, you should have an acute unit where patients who are worsening and a malignant MCA or a decompressive craniectomy facilities are possible. And also, you should have facilities for stroke research. So these are the extra mandatory points which are required in a comprehensive stroke care unit, where you can educate the patients and also at the same time do stroke research. So coming to the stroke unit, currently the Indian Stroke Association and also the World Stroke Organization is planning stroke certification all over India, and they have formed performance measures and quality measures which should be there in a stroke unit, whether it be a primary or a comprehensive care unit. So if you look at at least a minimum quality of care which should be there is, we should have, all patients should have a swallow assessment done as soon as the patient is admitted, and only after they pass the swallowing, they should be started on feeds. Second is with regard to the starting of the DVT prophylaxis in patients with ischemic stroke, and deciding on the later starting of DVT prophylaxis in the hemorrhagic stroke. All patients should have aspirin started. If the patient is in a thrombolytic time window, they should have received thrombolysis, and if there is contraindication, should be clearly mentioned. If a patient is after a stroke, early rehabilitation, what we are talking about is if the patient is clinically stable and neurologically stable, after 24 hours, the patient should be started on active rehabilitation. All these performed quality measures should be available. And with regard to the certification, they have also involved the performance measures in the form of what we have discussed already with regard to antiplatelets to be started within 24 hours. All cardioembolic patients should be discharged on anticoagulation. Statin should be started in all patients, and stroke education should be given when the patient is discharged, which is very, very important aspect of stroke care, because acutely managing alone doesn't make a difference. It should be the secondary prevention and the control of the risk factors, which is going to prevent stroke later in these patients.
Dr. Maheshwari, do you have more questions for? I think there was a question on how to manage stroke in women. Or
Yes.
what is special about stroke in women?
Yeah, that's no, sir. Now that repeated calling is for the Dr. Sunil Narayan.
Okay, right. I'll leave it to you.
There's a link. Just in a 2-3 minutes, I'm coming up, winding up. He is Professor, Senior Scale, Department of Neurology, JIPMER, Pondicherry. He has got an interest in the stroke. He is at present President, Tamil Nadu Academy of Neurology. And he is also Chairman, Stroke Subsection, Indian Academy of Neurology. Dr. Sunil Narayan, the query is, when do you involve neurosurgeon in stroke? And also the second query is management in subarachnoid hemorrhage. Of course,
Thank you,
part
Father.
is being answered by the Kameshwar Prasad, but a specific query to you.
Thank you. I do happen to be a neurophysician who is taking care of the stroke unit and the stroke program in JIPMER. But I'll be happy to take, because most of these cases do come to physicians and neurologists. So is there a specific question, sir? Or
Yeah, sir. When the neurosurgeon to be called in stroke, his intervention.
all right, okay. So it's in any stroke, not specifically in subarachnoid. All right.
What is stroke?
Right. So as you know, by stroke we usually mean ischemic strokes, but we also have this intracerebral and subarachnoid hemorrhages, both, and also the spinal infarct and hemorrhages. These are all coming under the broad category of strokes. And the classical situation where a patient should be ideally managed in an intensive neurosurgical unit is probably the subarachnoid hemorrhage, where a patient comes with classically in around 40 to 60 years age group, a patient suddenly developing what is generally described as thunderclap headache, a kind of a headache of excruciating type, which patient usually describe he has never experienced earlier, and then immediately followed by headache and vomiting. Nausea and vomiting, and usually with some dizziness, and very often some photophobia. And mind you, in this kind of situation, sometimes a patient can still come walking to your OPD. I had patients with a severe headache coming with with these symptoms, headache, vomiting. We always think of, whenever there is a nausea and vomiting, we think of intracerebral or subarachnoid hemorrhage as well. And if you do a clinical examination, fundus subhyaloid hemorrhage may be seen, but most oftenly it's not seen. But if you look at the signs of meningeal irritation, these are almost always present unless it's a very small bleed. So if you see subarachnoid hemorrhage, even if you see a patient who has come with this history walking, with this classical history of severe excruciating headache, we have to suspect a subarachnoid hemorrhage. And then the management is immediately looking for a CT scan, including a contrast CT scan to see the CT scan, plain CT itself diagnosis helps in the diagnosis of subarachnoid hemorrhage most of the time. And once it is found, it is ideally immediate reference to a neurosurgeon with the capability to intervene. Interventionally is necessary because these cases can rebleed, which can be fatal. And there also we need monitoring to prevent the complications like diffuse vasospasm leading to deterioration of the stroke, and also development of hydrocephalus, etc., which all need neurosurgical intervention as well. But apart from that, cases will need a neurosurgeon's intervention. The other situation is when patient has presented with large intracerebral hemorrhages. Not every case need a neurosurgical reference. We can, but the plain CT will always show when there is a significant intracerebral hemorrhage. The classical site is a putamen in a hypertensive patient, but posterior fossa hemorrhages like cerebellar hemorrhages, thalamic hemorrhages, these are all, and cortical hemorrhages, these are all the other common situations. Whenever there is a mass effect or deteriorating consciousness, or in the neurosurgeons usually say if there are more than 1 to 2 millimeters of shift in the midline shift, these are all situations where neurosurgeon needs to consider active interventions. Even in posterior fossa, sometimes a cerebellar hemorrhage will produce obstructive hydrocephalus. So initially a tapping of CSF or a ventriculostomy will be life-saving, followed by the decompression procedures. And this takes us to the decompression procedures. In a large middle cerebral artery infarction, more than 1/3 of MCA artery involved, we have to always anticipate patient going in for an infarct with a very with a mass effect. And here we have to monitor the patient carefully with immediate neurosurgical involvement. The monitoring, serial CTs may be necessary. And here the life-saving, we know that it's one of the most important. If you look at the number needed to 3, it is as low as 3 in saving lives. So anterior cranial fossa, a very generous craniectomy, and in posterior fossa, again, posterior craniectomy, sometimes the cerebellar hemispherical excision. These are very often life-saving situations. And nowadays, we do see patients of very large MCA artery infarct or the prompt neurosurgical, prompt decompression surgeries walking to the clinic after about 8 to 9 months. We have started seeing this regularly. So that's and it's not that all of them have got very bad prognosis. There was a time when we were worried, is it worth saving their lives? They are going to live a life of complete dependency. But we are with very good intensive care unit, with better understanding of the management of the physiology, especially the cerebral hemodynamic management in the acute phase. We have been able to get good recovery in these patients. And we do see a number of these patients are very, very gratifying to see them walking and coming to the neurology clinics or the follow-up stroke clinics. So these are the most important indication. The management of aneurysmal hemorrhage by a neurointerventionist or a neurosurgeon is very important. So they do specific procedures to clip the aneurysm or to put glues and bypass the aneurysm. So these way the rebleeds can be avoided, and that is an area where you need to take the immediate help of the interventional neurologist or the radiologist or the neurosurgeon.
Thank you. Sir, my question is, so this is the area for the hemorrhage. My question, if there is infarct, what is the area we can call surgeon or interventionist?
Oh, surgeon versus interventionist. Okay.
In case of infarct.
Right. I think the role of the surgeon, I have already informed. In the role was the role of separating between an interventionalist versus surgeon comes mainly in the secondary prevention. Suppose we had a patient with a significant had a TIA or a minor stroke, and there is a significant carotid stenosis. It is thought that in the first 2 weeks for an ipsilateral stroke or a minor stroke or a TIA, with a significant carotid stenosis, that is 80% or more. The first 2 weeks, actually, it is better managed by a surgical procedure, endarterectomy, rather than by an intervention. But by around 1 month, there is no any superiority which a cardiac endarterectomy may have is almost balanced by the endovascular stenting procedure as well. So I think, and also there are situations where patients above the age of 80, the female patients, female diabetic above 80 kind of patients, they are also patients for surgical intervention for secondary prophylaxis of the carotid stenosis. And also when there is a problem with if the stenosis is high, intracranial stenosis rather than the extracranial one, then the surgical access is difficult or impossible. Then we will have to take the interventionist help. And if there is a significant tortuosity of the blood vessels, either at the in the neck, then the procedure is difficult by endovascular procedure. Endarterectomy is better. And some of our radiologists say that even if there is a significant tortuosity at the femoral artery level or iliac artery level, again, it might be better to do the surgical procedure rather than the endovascular procedure.
Yes, yes. So to summarize for the residents who have to give the very to the point answer in the exam, the indication of surgery for hemorrhage should be large mass with a herniation, cerebellar hemorrhage more than 3 centimeter, subarachnoid, subdural. For carotid artery stenosis more than 70%. This is the very brief for the physician's level.
Yeah, I would agree with that. Yes.
Neurosurgeon for opinion.
These principles stand. I mean, we all practice.
Yes, yes.
Thank you, sir. Because the time is short. So now next panelist is Brigadier Gorthi. He is Professor and Head Bharati Vidyapith Pune, and also he has got the publications in national and international journals. He is also the convener of the subsection of stroke in Indian Academy of Neurology. And question is, stroke in women, what is unique and unknown? And the second, very brief, is when to start the neurorehabilitation.
Thank you, Dr. Maheshwari, and for inviting me to participate in this prestigious symposium. Yeah, first question is, what is unique to stroke in women? One thing is, women live long than men. So, and all the stroke trials, they have strokes more than 80 years of age, and none of the stroke trials have included them in their studies. So that's another problem with women in stroke. And you know, stroke in women is Kaplan textbook of stroke plus, because there are factors which are reproductive associated and reproductive non-associated. So the etiology is somewhat very different there. And they have normal, non-traditional factors and traditional factors also. So reproductive factors like hypertension associated eclampsia, preeclampsia, PRES, reversible cerebral vasoconstriction syndrome. Now all those things, if there is a migraine, all these hypertension associated problems will increase tremendously. That's one group. They are also subjected to all these atrial fibrillations, AV malformations, diabetes related, chronic kidney failure, coagulopathies, and all these things will come. Now, what is unique is there is no actual difference because the studies have not included, we are not able to brought out the difference. But one thing very symptoms, they present in a very non-traditional way. Their symptoms are always very mild headache, confusion, disorientation, fatigue, non-focal weakness, and all these non-specific, non-traditional symptoms they present with. And also there are a lot of stroke mimics in them. And the stroke mimics, most of them 30% up to 30% are known to be non-organic. So it's very difficult to diagnose and timely institute treatment for them. The question comes whether we can thrombolyze in acute ischemic stroke cases. Before we go to treatment, we have to investigate them. The common physician's problem is, can I do NCCT in pregnant women? And that's a main issue. And if you think the diagnosis of stroke is paramount, and we can do non-contrast CT scan. What other investigation you should do? And that's one thing which we used to be afraid of doing that, but effects of radiation we should keep aside because stroke is paramount important. We should do because if there is no facility of MRI in remote areas. Second, if there is a possibility, we should do a CT angiography to identify the infarct-related artery. So that's another important issue which all the students should know, that infarct-related artery identification is very important to diagnose large vessel occlusions and subsequently endovascular therapy is to be instituted. So etiology we have already. Demography, the one interesting point is that the reproductive age of the woman dictates the incidence and prevalence of stroke. If a lady attains menarche less than 10 years and menopause is early, they are more likely to have strokes. And ladies who have preeclampsia are more predisposed to have strokes. So these people should be kept under under watch and institute treatments as early as possible. So that's one thing which I wanted to say. Another thing is what in treatments and treatments. Thrombolytic therapy doesn't cause the recombinant tissue plasminogen activator, doesn't cross the placenta and cause any harm to the baby. But you have to decide whether it is a maternal bleeding is a problem in case of placenta previa and other abnormalities or coagulopathies. You may not like to thrombolize, but it doesn't do any harm to the baby, and that's much sure because it doesn't cross. That's one of the important points. And some of these cases, when you want to put them on thromboprophylaxis, we cannot give oral anticoagulation. So what we do is we give low molecular weight heparin or regular and low dose aspirin can be given. Another important aspect of women which we can think is we have to recommend actively. That's very important because physical activity is less in these people. So at least 75 minutes per week, they have to indulge in vigorous. We have to encourage them to go for vigorous physical activity. If it is moderate and vigorous, it may be about almost 75 minutes. So 150 minutes. This much exercise, we have to encourage them to do. Most of the ladies, they don't do that much exercise as men do. That's a major difference between. So as we can see that there are differences in stroke. So because time is short now, I'm going to the second part of the question. What Dr. Maheshwari said is about neurorehabilitation. Many aspects have been touched. And one of the interesting questions that has come up in the chat box was, what is the position of the head which is to be kept? And it's 30 degrees to reduce intracranial pressure. One more important issue which I would like to mention, the positioning of the alignment of the spine along with the neck to avoid the writing reflexes that originate from the neck. We have to keep them in a particular, say, a center position. And also that, no, it's better not to put any lines in the neck. And you use other lines, peripherally inserted central lines are very advisable because that will affect again intracranial pressure. So two are important things, the positioning of the head, and second is as much as possible, we avoid the lines. And of course, we have to take all the precautions to prevent the bed sores, aspiration, pneumonias, and of course, some reference has been given to the swallowing test, which is very, very important. And it is better not to do nothing by mouth for 72 hours, and beyond 72 hours, if diet can be started. So it's a very good practice not to give any feeds before that. So I'm just concentrating on an acute stroke, and there is a chronic stroke management. But acute stroke, we have to prevent the fever, and hyperglycemia has already been mentioned. Hypertension has already been mentioned, as swallowing. And these are the more important issues in the first 72 hours. If you take care of these 4 items, the yield is much better than thrombolytic therapy alone. If patient doesn't get thrombolytic therapy, but in ICU in the first 72 hours, if you say that their temperature is unraised, the sugar is well kept under 140 and 180 range, and the blood pressure is optimally managed, and you have taken care of the swallowing, and that will give a good, very, very important outcomes at the end of 3 months. The other one is about the bed sores, and you should prevent bed sores, 2-hourly change of the positions. And usually the physiotherapy, there is a very book, very useful handbook by Dr. Sailaja and Sri Chitra Tirunal Institute, and it's freely available on the net, and one can download it and see. The physiotherapists and you people should form a team to learn these techniques of positioning and how to prevent the shoulder pain, stiffness, and all that will come into that. And this has been very, very well explained in that book. And because of lack of time, I'm not going to the details, but you should. One or two interesting things which I would like to tell is the constraint therapy and the mirror therapy. And here in constraint therapy, what you should do is you package the normal hand when the wrist in the abnormal hand is at least 20 degrees movement and there is some flexion of the fingers. And what it does is 8 hours, you completely bandage the normal arm and ask him to do every task with the affected arm. So that will stimulate then the brain plasticity and there will be connections re-established. Maybe the action potentials will start getting generated. So another thing is you put a mirror and you see the hand, the hand which is on the back side of the mirror is the affected hand and front is a normal hand. And when you start doing movements with the normal hand, the brain gets a stimulus and there will be rehab. So these are some of the techniques which are very, very important. I think with this, because of Dr. Maheshwari is already looking at me to finish. So that I got your message and thank you very much.
Thank you, sir. I want to add one point. As per literature, females have more aneurysmal bleed, but males have more a hypertensive bleed. This is one difference between male and female.
But in female, but hypertension in pregnancy is another risk factor. You know, what they say is at least 5-fold increase in the bleeds in the strokes, both male. Maybe ICH is different, but the overall stroke incidence is more in females when there is a hypertension. When there is hypertension.
Sir, another important issue as from the physician's viewpoint, when we follow up the patient day to day after recovery of 48 hours or 72 hours, with the sodium estimation, we basically look for the hyponatremia. We are less aware about the hypernatremia, but the hypernatremia has a worse prognosis than the hyponatremia. So all the resident and physicians should be very aware of the hypernatremia in the follow-up period and should treat accordingly.
Agree? If you have facility, do it. In remote areas, it may be difficult, but the important issues exist.
And sir, Dr. Jyotirmay Pal, sir, the question for you.
Yes, sir.
Dr. Jyotirmay Pal is Dean ICP, Academic Wing, and also he is a professor in Government Medical College, Kolkata. And now a commonly used practice for you that when to use anticonvulsant and which one in a stroke patient. Second, role of steroid in stroke. And third, role of osmotic diuretic like mannitol in stroke, because a lot of the prescriptions are filled up with all these three things.
Yes, sir. Already the answer is given during the lecture of Dr. Professor Padma. But just to elaborate, regarding the last question, the steroid. There are so many studies starting from 1972 till now. There is no proven role of steroid use in stroke patient. It has no added benefit other than it can invite so many infections, except in one condition when the vasculitis is the etiology, but vasculitis incidence is less than 1%. So this is one part. Second part is the anticonvulsant. Again, there is controversy whether we will use prophylactically or in a patient with proven seizure. So class 1 indication is basically a patient with a clinical seizure or recurrent seizure or EEG has demonstrated the seizure. This is the class 1 indication. You can start with the phenytoin, you can use the carbamazepine, you can use the valproate or levetiracetam you can use. And if you use in a symptomatic seizure of the phenytoin, you can continue up to 3 years, and depend on the situation, if there is a more gliosis or recurrent seizure, you can use for the longer period. This is one part. Second part, class 2 indication, if the patient have ICH and you are deteriorating mental status and you are suspicious about the epilepsy or EEG have a probable seizure, there also you can use the anti-epileptic drug. So if the EEG proved seizure or doubtful about the seizure, whether they have the motor or non-motor manifestation, you can use the seizure. But for the prophylactic use of anti-epileptic drug, there is no clear role. So this two part is very clear. Third part is the osmotic agent. This is very important because this is to reduce the intercerebral hemorrhage, intercerebral edema, intercerebral pressure. So the drugs that are used to reduce the intercerebral pressure, one at the beginning you start with the mild restriction of the fluid, some fluid elevation, somebody has put the question how much elevation is needed, around 20 to 30%, and avoid the factor that increase the ICT, such as hypoxia, hyperthermia, hypercapnia that has been described during the delivery of the Dr. Padma. This is one part. Second part, you can use the agents like mannitol or fusimide. So mannitol is a agent, fusimide you can start with 40 milligram, you can repeat with another dose of 20 milligram, and mannitol you used with 0.5 to 1 milligram per kg up to over 20 minutes, and you can repeat every 8 hours up to 3 to 5 days. This is the rule of mannitol, but during the mannitol administration, you remember of the few complications such as hypovolemia, or patient have the impending heart failure, patient can go the heart failure because there is a volume overload, or hypotension, some electrolyte abnormality, some metabolic acidosis. So during the use of mannitol, you keep these issues in your mind. Or fourth is the hyperventilation, that you can intubate and can do the hyperventilation. That is also another proven measure to reduce the ICT. If you keep the carbon dioxide between 30 to 34 millimeter of mercury, and some decrease of the carbon dioxide up to 10 millimeter can decrease the ICT by 25%. So these are the 3-4 proven measures by which you can reduce the ICT medically.
So thank you, sir. Because you
Dr. Maheshwari, just one point which I forgot, which is very important. Since you asked the question about neurosurgeon versus interventionist in the management, Dr. Paul was asking. So whenever you are referring a patient for endarterectomy, just make sure that the surgeon has a reputation of less than 2% mortality, and also at least an experience of about turnover of around 6 cases per year. And that is the general recommendation. Suppose we are starting the procedure, a new, if we start doing it first time in our institution, the surgeon should work supervised by the other experienced surgeons. So the experience of the neurosurgeon or the vascular surgeon in endarterectomy in the preceding years, that's extremely crucial in deciding whether we can refer for endarterectomy and to whom to refer to endarterectomy. Thank you.
Yeah, so my request to Dr. Jyotirmoy Pal, Dr. Gagandeep, and Dr. Girish Mathur, being ICP academic wing, that why don't you make up with a joint collaboration the monographs on the 4 things. One is a stroke, another is a seizure, third is a CNS infections, and the head injury, because that will circulate it to all the ICP members and also to the API. My request only.
That's a very good suggestion, and I'm sure Dr. Pal and Dr. Mathur and everyone at the API would pursue. And I can say on behalf of my dear friends and colleagues in the Indian Academy of Neurology that we are really going to be, we would offer all kinds of cooperation for this. So certainly that goes without saying.
Sir, as Dean, I will write a letter to you with copy to Dr. Maheshwari. What I propose, it is not the complete guideline, it will be more a question answer basis, issue based. The issue is when you will use the antiplatelet, if the patient has mechanical heart valve, in which day we start the anticoagulation. So it will be more a question answer basis. So it will be like a more ready reckoner. The physicians practicing, what are the issue challenge come, they will get the answer immediately in the book. So 4 issues, whether we can cover it up.
It's an excellent idea. Yeah.
So I write to you with my idea.
All of us would be more than happy.
Yes.
Dr. Maheshwari, I think we are a little beyond time.
Yeah.
Questions for Dr. Mugandan and Dr.
Mugandan. One question.
Quick questions, please.
how you prevent the hypostatic pneumonia in a stroke patient.
Very important.
Sir, first of all,
And
I
also the
thank
aspiration.
IAN President Dr. Gagandeep Singh sir for asking us to organize this IAN APA symposium. And the serious and common complication of stroke is pneumonia. It is frequently caused by aspiration. In hospitalized patients, due to this neurological injury in neurological patients, they have weak swallowing reflexes who are susceptible to development of aspiration. Then an AT tube is inserted to help to protect against the large volume aspiration, whereas it will not help to eliminate the smaller aspiration. And also the ET tube also interferes with the normal defense mechanisms such as cough. And also in neurological patients, due to reduced or decreased mastication and swallowing, these patients with stroke are vulnerable to disruption of the normal oral microbial agents, which carries poor prognosis. So stroke associated pneumonia is diagnosed by the progressively increasing infiltrative lesions in post-stroke chest images and newly occurring cough and other signs. The serious illness in bedridden patients, because there is no movement in the stroke patients, where there is deterioration in ventilation and also sputum accumulation in bronchi, which results in inflammation of the organs causing hypostatic pneumonia. So there is a ineffective airway clearance, which is related to the decreased cough reflex, which can be rectified by increased fluid intake, encouraging coughing and side-lying position, and bronchodilator and chest therapy, chest physiotherapy. So how do we measure and manage for the silent aspiration or apparent aspiration? So as Professor Gorti also mentioned about the swallowing reflex. So first we have to elevate the head end of the bed during night and clean oral cavity. We have to prevent dehydration and improve nutrition. And we have to discontinue sedation and sleep medication. And we have to maintain head-up position during daytime. So the measures and management for apparent aspiration, we have to encourage the swallowing rehabilitation, and the eating assistance has to be there in stroke patients, and the swallowing training has to be done, and strengthening of swallowing muscles, and the continuous action of pharynx. And we have to do measures to prevent gastroesophageal reflux disease. Then postural modification is a must, because it may aid in prevention of this aspiration in patients, and also which causes and also improves the oral hygiene. Lastly, the early dysphagia screening is necessary in post-stroke rehabilitation, where it helps and prevent the aspiration. So with this, I thank Dr. Maheshwari for answering this question.
Thank you, Dr. Mugandan. As the time is very short.
Sir, one point to add: in the hypotensive, there is pneumonia, you should give a good gram-negative coverage, because mostly infection happens due to the microaspiration from GI tract into the respiratory tract that carry the many gram-negative bacteria. So good coverage of gram-negative coverage should be given when you are facing such type of pneumonia.
Thank you, sir. In the question section, I think that the majority of the answers have already been given by the different panelists. And the time is short. And for the saying the vote of thanks, may I invite Dr. Gagandeep and Dr. Jyotirmay Pal to end up today's webinar.
You want to ask one, you had one question for Dr. Bansal. A very quick one, please.
But he is very much reluctant. And one question is there: how do you manage the UTI and the bed sores in a stroke patient? Last but
I think Dr. Maheshwari thought that bed sore is the last complication which occurs in a stroke patient. So most of these two things have been covered. UTI, both of these are complications are preventable, very common, and very serious complications. UTI is very common. The incidence is around 40%, a range is between 10 to 60%. The variability is because of age, gender, mobility, bladder function, and presence of diseases like diabetes. Dr. Padma has already mentioned that one should use coated catheters and take meticulous care of catheters. But before putting in catheter, one can do good hygiene. Clearing of genital areas daily, especially after passing a motion, and regularly going to the bathroom, even if there is no urge, to prevent stasis, and meatal care and using of antiseptics in the urinary bags, although it has not been proven scientifically. As far as bed sores are concerned, they're also very common. The incidence is between 8 to 36%. The variability depends upon the overall individual health, stroke severity, and level of care in a particular hospital. The common risk factors are immobility and poor nutrition, incontinence, and loss of sensation in that area. Preventive measures, of course, is, as has been mentioned by Dr. Gorthi, change the position every hours, good hygiene.
I think there was a connection problem, so. Right.
I think the time is over, so IN digital team is also calling that 2 hours more than 2.30.
Right. Dr. Pal, Dr. Jyotirma Pal, would you like to say something, and then we'll conclude?
Yes, sir. Thank you. I am thankful to Professor Govindra Singh, all the panelists, all the delegates, and Dr. P.K. Maheshwari taking lot of, and most importantly, the student and audience, they have participated. This program is success for them only, and I will go to all physicians across the country to participate in such type of webinar, joint collaboration with the other societies, and hope we'll come out with some common status paper, question answer basis that will be very ready reckoner for the practitioner and the residents for their exam. Thank you, sir. Thank you.
Fantastic. Thank you. Thank you, Dr. Paul. Thank you for those excellent suggestions. And thank you for, of course, as you said, the first big shout goes to the audience. Thank you for being there. The excellent speakers, Dr. Padma, Dr. Joshi, Dr. Murgunath, wonderful talks, and the real expert panels, Dr. Kameshwar Prasad, Dr. Subhash Kaul, both my teachers, and then so many of my friends, Dr. Sunil Narayan, Dr. Sailaja, Dr. Gorthi, am I missing out? Bansal, and Dr. Mugandan. Excellent. Thank you so much. I think it's been, I'm not a stroke person, and I learned a lot from you, all of you. Thank you so much. Thank you. And I conclude the day. Thank you so much.
Thank you. Thank you.
Thank you, sir.
Thank you. Of course, Dr. Maheshwari, the biggest shout to you. Sorry. Yeah. Right.
Thank you.
Thank
you, Dr. Maheshwari. Thank you.
Thank you, Dr. Maheshwari.
Thank you.
Thank
All
you.
cooperation ensured from my part. Thank you.
Actually, thank you very much. Good night to everybody.